So good evening and welcome to all. Greetings from Sexual Medicine Committee Foxy. My dear friends, today again we are here for a unique webinar which are actually webinar which included the topics which are really unspoken, untreated, and actually we always neglected. But my dear friends, this topic, the topic about the very sexual problem, we gynecologists are there who have the first contact, and patients actually come to us for treating with this. So this is our sincere, effort from the Foxy Sexual Medicine Committee to give this basic information to all the gynecologists. So thank you so much to all the 5 societies of Uttar Pradesh, Aligarh, Mau, Jaunpur, Khora, and Aligarh societies to who accepted to be part of this webinar. So I welcome to all from bottom of my heart on behalf of Sexual Medicine Committee. My dear friend, before we start our program, I would like to invite the person behind all this program. This all program is a brainchild of our own chairperson, Dr. Neeraj Jadhav, sir. So I would like to invite Neeraj Jadhav, sir, to give a overview of this program. We all know Neeraj sir is at present the Foxy chairperson of the Sexual Medicine Committee and vice president of the Rajkot Menopause Society. So thank you so much, sir. Sir, over to you for overlighting of this program.
Thank you, Apurva. So, on behalf of Sexual Medicine Committee, I welcome all of you, all the speaker, all the chairperson, all the president and secretary of the Sex Society who are joining for today's webinar. So, why sexual medicine? Because sometimes we thought that sexual medicine is not a part of gynecologist or obstetrician's practice. It is a domain of the sexologist. But obstetrician and gynecologists are the woman's favorite healthcare personnel when talking about their sexuality, and so have to deal with women's sexuality every day in their offices. Reproductive health is also encompassed that women have safe and satisfying sexual life and are capable of reproduction as per their disease. As gynecologists, we have to improve the quality of women's reproductive and sexual health. But doctors' own attitude, discomfort, and reluctance to discuss the sexuality related issue with may stem from their inadequate knowledge in the field of sexuality. Many societies consider sex as a taboo, and even married women do not talk about their sexual matters. Gynecologists are also part of the same society, so talking about sex may be difficult for both doctor as well as the patient. So gynecologists need to have their own comfort as well as confidence in discussing and treating the sexual health issue. We also face time constraint in our busy OPD. We have so busy OPD. We have a labor patient in the OT. We have full OT. So sometimes it's difficult to spare time because in sexual medicine, main part is the history, and it takes long time to take history and to counsel such type of patient. But believe me, we don't have to be sexologists to manage our patient with sexual medicine. We do so many basic practice, like we do basic sonography practice, we do basic infertility practice, we do basic oncology practice. Same way, we can manage sexual medicine practice in our day-to-day practice. We don't have to be expertise in the field of sexual medicine to manage such type of patient, but only little bit inclination towards the sexual medicine can benefit our patient a lot, and we can have a much impact on the overall health of the patient, because sexual health is a very important part of women's women's health, and we have a role to play. So it's our effort from the Sexual Medicine Committee to reach all the Foxian in all part of the India. We have done so many programs in different society, and we try to make them familiar with the subject of the sexual medicine, so they can start taking interest in the field of sexual medicine and manage their patient with the sexual health problem. So I am sure after today's webinar, you will take more interest in the sexual medicine, and sexual medicine is a part of obstetrics and gynecology. It's because in India, it is a due to so many factors, there is a no specific recognition for the field of sexual medicine, but we can do that, and I hope that we will day by day with our effort we will change the scenario in the coming days. So I welcome once again every one of you, and I expect a very interactive webinar today because this is a new topic. So all of you will be having so many questions and so many confusion. So we have very distinguished speaker with us who are the part of our sexual medicine committee. You can ask your doubt and solve your queries about the this topic. So happy learning to everyone and welcome.
Thank you, sir.
Over to you, Apurva.
Thank you so much, sir, for your kind briefing and introduction. So without wasting the time, we in our culture start any program from the blessings of the seniors. We have a very special guest with us, our guest of honor, Dr. Yashodhara Madam, Dr. Asha Rathi Madam, and Dr. Kusum Verma Ma'am. So Dr. Yashodhara Ma'am is not here. She will be joining in a while. So I would like to hand over to Madan Kamble sir, my co-moderator, to invite and getting blessings from our guest of honor. Madan sir, over to you.
Yeah, thank you, Dr. Apurva. Thank you, Dr. Neeraj sir, for making me part of this wonderful webinar. I'm privileged and honored to welcome the guest of honors of today's webinar. Yes, I welcome Dr. Asha Rathi ma'am. She is the director of Rathi Hospital, Aligarh. Also, she is a patron of Aligarh Obstetric and Gynae Society. Also patron of Ganga Seva Samiti. She is patron of Dehradun Kartavya Samiti and also the past president of Lions Club Jagruti Aligarh. I would like to request ma'am to have some words of blessing. Over to you, ma'am.
Asha madam.
Hello, everyone. Good evening. This evening is very nice and really at the base of the universe. As everybody knows, the sex is a part of a life and the demand of the body. But end result of sex and the progeny which grows, it gives a pleasure all over the world. And this is the universal cycle which goes on. But as a gynecologist, we never go deeply into it. We usually advise them all the things, but not deeply into it. And this is a good thing from the Sexual Health Committee. They have initiated, and my all the blessings to them for the initiation and for the continuation, and it should be continued because this problem is day-to-day problem, and this problem solves so many problems. If this problem should be solved, I think the test tube baby will be lesser in number and the normal pregnancy and normal health being will be better in the future also. As far as I know, Fred also said, everything is just behind the sex. But as it is unspoken, but now we are trying to speak for it. It gives me a pleasure. I should have a words for it to talk to the patient, and I will be more welcomeable to for the inner thoughts of the patient. I will be able to understand. In this, I want to tell you something which is my personal experience. More you educate, more you educate the child, they are so much in the studies, they doesn't know the normal body demand, and normal sexual functions also. My nephew is a oncologist. But in spite of this, 2 months after marriage, he contacted me. I'm not able to do it. What should I do? One of my IIT relation, he has also contacted me after 1 month. What should I do? Because this gives me inner thought. I may hurt her. Not a good thing, or this may
second thought में हाँ
शेयर स्क्रीन में ऐसे क्लिक करना है
हाँ।
सॉरी
फिर उसमें से भी तो कुछ लेना पड़ता है
I think with the discussion, we can have a future plans also, so that we can discuss the things, and we can also premarital counseling can be promoted with this platform. Thank you very much.
Thank you, Asha.
Thank you, Asha ma'am, for your kind words and blessings. I would like to request Dr. Kusum Verma ma'am. She is a senior consultant and president of Mau OBGY Society. Over to ma'am for your kind words. Kusum ma'am.
Good evening.
Kusum ma'am, you are
Good
on.
evening.
Yeah.
Yeah.
I am audible.
Yes,
Yes, ma'am. Yes.
Good evening.
Good
It's,
evening.
I am highly obliged that you, Dr. Apurva, that he made me a part of this wonderful series. Actually, this is very untouched topic. As Dr. Asha said, that it is very important that we should inspect through in this topic, and because it is very important for youth and for other public also. And I hope that this webinar will be very effective, very informative to all of us. And I hope this Dr. Apurva will continue this type of webinar for learning period. And I wish successful of this webinar. Thank you.
Thank you, Kusum madam.
Thank you, ma'am. Thank you for being with us today. I would like to hand over to Dr. Apurva sir for further proceedings.
Thank you so much, Dr. Madan. Thank you so much, Asha ma'am and Kusum ma'am, for your kind words and your blessings. So without wasting the time, we will start our the scientific session. And for chairing the first talk,
No.
I would like to invite just 1 minute. I would like to invite Dr. Amita Singh ma'am, Dr. Pragati Agarwal ma'am, and Dr. Garima Tyagi ma'am. So, my dear friends, Dr. Amita Singh ma'am is the director of Ma Charitable Hospital Balia and partner of the Nursing Home Association Balia. She is the past president of the Inner Wheel Club Balia. So, welcome ma'am. Thank you so much for your agreeing and presence here. I would like to invite Dr. Garima Tyagi ma'am. Ma'am is the director of the Sri Narayan Hospital at Indrapuram, Ghaziabad, joint secretary of Khora Manpur OB Society. Welcome ma'am. Thank you so much ma'am. And my dear senior and very good friend Dr. Pragati Agarwal ma'am. Ma'am is the senior consultant and the secretary of the Bareily OB Society. So I would like to invite Dr. Amita ma'am to invite our first speaker for the day, and Dr. Sama Sultana. Over to you, Amita ma'am.
Thank you, Dr. Apur.
Thank you so much.
Am I audible,
Yes,
Dr.
ma'am.
Apur?
Yes, ma'am. You are audible. You are visible. Yeah.
Yeah. Thank you so much. Firstly, I congratulate all the team for this webinar and the untouched topic of the gynecologist. And now I introduce Dr. Sama Sultana. She is the chief gynecologist and chairwoman of Hope Win Hospital, Guntur, Andhra Pradesh. Welcome, Dr. Sama. We are waiting for your talk.
Thank you so much, ma'am. And I welcome to the scientific session. And really, it is an untouched and unspoken topics which we discuss here with the grace of our all seniors and Neeraj sir. From last April 2021 April, I am with Sexual Medicine Committee, and I proudly say that I have changed my the way of I interact with the patients. And today's topic, which I'm going to take, is FSAID. And really, this topic has made the really change in my practice, because this question that a couple, when I asked to a couple that would you be showing the interest, you and your spouse are showing interest in the sex regularly, or you don't have it, or it is some stimulating thing, or when we do ovulation study, they are feeling it as a stress as well. So this topic, female sexual arousal or interest disorder. So first thing, female sexual dysfunction. Female sexual dysfunction occurs when a woman is not able to fully, healthily, and pleasurably experience some or all of the various physical stages the body normally experiences during sexual activity. These stages can be broadly thought of as desire phase, the arousal phase, and the orgasm phase, and the sexual dysfunction also includes painful intercourse. And the components of female sexual dysfunction would be sexual desire disorder, orgasmic disorder, sexual pain disorder, and sexual arousal disorder. Today, we are interested in sexual desire disorder and sexual arousal disorder in this topic. And whereas we see the classification, precisely, I want to say that female hypoactive desire disorder is named as now female sexual interest or arousal disorder. And first of all, need to know about the terms that sexual interest refers to the motivation to engage in the sexual activity. Interest is commonly referred to as a desire, sex drive, and sexual appetite, and describes the sexual feelings motivating a person to seek some type of sexual activity, whether partnered or alone, like masturbation. Then sexual arousal is conceptualized as the second phase of the sexual response cycle and defined by both physical and mental readiness for sexual activity. Physiological changes occur in the body to prepare for a sexual interaction, that is vaginal swelling and lubrication in the females. So as we see, this has a DSM-5 has a criteria. First thing is a woman must have 3 out of these 6 symptoms, like she should have an absent or reduced interest in the sexual activity, or absent or reduced sexual thoughts or fantasies, or no or reduced initiation of the sexual activity, and typically unreceptive to the partner's attempts to initiate, and absent or reduced sexual excitement or pleasure in almost all or all sexual encounters, and absent or reduced sexual interest or arousal in response to any internal or external sexual cues, and absent or reduced genital or non-genital sensations during sexual activity in all or almost all sexual encounters. And also other criteria, like the symptoms in criterion have persisted for minimum duration of about 6 months, and the symptoms in criterion cause clinically significant distress in the individual, and the sexual dysfunction is not better explained by a non-sexual mental disorder or as an consequence of severe relationship distress, partner violence or something, and or significant stressors, and is not attributable to the effects of substance or medication or another medical condition. And specify whether it is lifelong or acquired, or specify whether generalized or situational, and specify current severity like mild, moderate, or severe. So types we can say like subjective, genital, and combined. Subjective means not aroused by sexual, genital, or non-genital genital stimulation, such as kissing, watching an erotic video, or physical stimulation. They are physically aroused but not mentally or emotionally aroused. Then genital arousal occurs in response to non-genital stimulation, such as viewing an erotic video, but not in response to genital stimulation. This disorder typically affects postmenopausal people. Vaginal lubrication and or genital sexual sensitivity is reduced. So combined is arousal in response to any type of sexual stimulation. is absent or low, and they are report low or no physical genital arousal. They may have a need for external lubricants and may state they know that swelling of the clitoris no longer occurs. So most of the overall causes could be smoking, relationship issues, depression, chronic health conditions, certain medications, fatigue, being overweight, or stress. So as we see the female sexual response, the very first stage, that is excitement, plateau, orgasm, and resolution, the very first phase, excitement, there people are just blocked due to this loss of interest and arousal. So causes, again, it is in a female body, sexual arousal increases blood flow to the tissues around the vaginal lining and clitoris, leading to swelling of tissues. In turn, the vagina produces natural lubricants. Any disruption in this process can lead to FSIAD. Then this psychological and physical factors both can disturb the arousal process, and also psychological factors, that is low self-esteem, poor body image, sexual orientation, anxiety, depression, stress, trauma, guilt, negative thoughts, and relationship problems. Then hormonal factors as well, fluctuations in the hormone levels can affect the ability to be aroused, and the factors that can cause hormonal changes and possibly FSIAD include birth control pills, menopause, and also pregnancy, etc. Anatomical factors on one part, that problems with the circulatory or neurological system of the body may cause FSIAD, as arousal depends greatly on these systems, and some of the causative anatomical factors include reduced blood flow to the vagina and damage in the pelvic nerves, vaginal and bladder infections as well, and abnormal drying or thinning of the vaginal tissues. And medications like SSRIs and antidepressants also be a part, like selective serotonin reuptake inhibitors also reduce it. And medical treatments like chemotherapy, radiation, recent surgery may affect arousal and normal sexual stimulation, and inadequate sexual stimulation, like the sexual stimulation received from oneself or partner, is not enough. And in diabetes, as it affects the nervous and vascular system, it may make arousal more difficult, and the body is not capable of sending the essential and exact signals and hormones for arousal. So here we see few physiological and organic factors like dopamine, norepinephrine, estrogen, testosterone, oxytocin, nitric oxide, and psychological, that cultural factors which are increasing, enhancing, that will turn on, excite, or faster, or it will make easier and greater response and hot. Whereas in other way, physiological and organic factors like serotonin, opioids, prolactin, endocannabinoids, and psychological cultural factors which decrease the interest and arousal will turn off, that is inhibit, slower or difficult, less response, and not will form the interest and arousal. So in another Besant's model, I want to say of female sexual response, where emotional intimacy is initiating, then it will go to sexual stimulus and sexual arousal, more arousal and sexual desire, and it will go to physical and emotional satisfaction. So neuroanatomy central, as I said, neurovascular, that is cortical and subcortical limbic system is involved in it, and also few neurotransmitters like dopamine and serotonin. Dopamine, which is helping in the activity in the areas which is involved in the sexual motivation for both males and females. Then in the case of lot of changes, parallel changes in the sexual behavior or motivation occurs in due to dopamine. Then serotonin, actually LH, important for stopping motivated behavior. Actually increase in serotonin will cause increased time to sexual arousal, contributes for the refractory period. Oxytocin as well, it is released from hypothalamus and also produces smooth muscle contractions, involved in vaginal contractions, ejaculatory mechanisms as well. And it also helps in the increases in dramatically during masturbation, and also involved in subjective arousal, feelings, and pleasure during orgasm. So pheromones as well, we say subjective means like a spouse is there or a partner is there whose pheromones are being attracted, means when the pheromones he is smelling, that he or she is smelling, then they form the thought and interest and arousal. So forces affecting sexual motivation are like physiological readiness and imagined stimuli and external stimuli. It will help in sexual motivation. So how we diagnose it normally, like sexual desire, we have a few instruments like Arizona Sexual Experiences Scale and Changes in Sexual Functioning Questionnaire and Female Sexual Function Index and Derogatis Interview for Sexual Functioning. And sexual arousal we see as a profile of female sexual function and sexual function questionnaire. And then this is the decreased sexual desire screener, in which few questions were asked. If they are saying a lot of S, that means they have a problem within. So we need to encounter and diagnose the main thing, and the patient, for suppose the diagnostic and statistical manual of this mental disorders, we have asked the questions like, in the past, was your level of sexual desire or interest good or unsatisfying to you, or has there been a decrease in your level of sexual desire or interest? Such questions, 5 questions are there. In this, if they are going on saying yes, yes, and that means they are towards the loss of interest and arousal. So the patient qualifies for the diagnosis of generalized or acquired HSDD if she answers yes to all the questions 1 to 4, and your review confirms no to all of the factors in the question 5. So the patient may qualify for the diagnosis of generalized acquired HSDD if she answers yes to all the questions 1 to 4 and yes to any of the factors in question 5. So the patient does not qualify for the diagnosis of generalized or acquired HSDD, hyposexual disorder, if she answers no to any of the question 1 to 4. So treatments we do as a female sexual arousal disorder, like we have to do a sexual sex education, cognitive therapy, create non-demanding situations, work on relationship problems, use of artificial lubricants or biological treatments like vacuum pump used on the clitoris, and medications also being investigated controversially. So the thing we need to discuss is who should manage it. Usually present to the gynecologist initially, and most gynecologists do not want to open the Pandora's box, like how they are getting interest, how they are not getting interest, are they being aroused when the partner is approaching to them, like that we have to go within. And the specialist referral should not be the routine practice unless requested by the patient, and serious psychopathology like psychosis, body dysmorphia, and resistant to conventional therapy, then we can refer to them to a specialist. Then resistant cases and presence of specific endocrine or anatomical disorders. So what are the effects we can see in a patient with FSAID? So in this, chronic stress, anxiety, depression, lack of concentration, insomnia, irritability, relationship conflict, and social withdrawal as well. And they have a low libido, as we see in the menopause. First we will discuss about, see, low libido after menopause, it's a misconception actually. And also obesity, which is mechanical difficulty in certain sex positions, and Kegel exercises we can tell, and change the timing, or like osteoarthritis was in evening, and rheumatoid arthritis was in morning. In that we can change the timings. Then hormone therapy for menopausal FSAID, like systemic HRT and tibolones we can use. Systemic HRT can improve sexual function and dyspareunia. Risks versus benefits, early initiation theory we can take up. And tibolone, it's androgenic and does not stimulate breast or endometrium, may be considered as the first choice as HRT in women with low libido. And local estrogen therapy, even in women on systemic HRT, vaginal regeneration is often inadequate without local estrogen. Improves lubrication and sexual function in case of vaginal atrophy, can be used safely in women for whom HRT is contraindicated, and the symptoms may return once they are stopped. So long-term therapy is often needed, and long-term safety data on use of beyond 1 year is lacking. So again, what I see is testosterone. What are the benefits? See, in this, there is a reduced insulin resistance and increased bone strength and density, healthier body composition, and improved muscle tone, higher energy levels, better emotional health, restoration of libido, and smoother, more youthful looking skin, and decreased fat and decreased cholesterol levels as well. Then symptoms, what do we get with low testosterone in the women? Cognitive impairments, increased body fat, poor libido, and impaired ability to build muscle mass, and depression. So androgen replacement therapy in women with low libido, the level of serum testosterone has been found to be lower than the age-matched control. So testosterone can be considered if despite HRT, the low libido does not improve, then conventional HRT increases this SHBG and reduces free testosterone, causing low sexual drive. And besides sexual and vaginal health, may improve cognition and bone health. So side effects, as usual, cosmetic, that is hirsutism and acne, usually milder form can occur, and irreversible virilizing changes like voice deepening, clitoromegaly are rare and occur only in the excessive dosing, and insulin resistance leading to increased susceptibility towards the metabolic syndrome, and most androgens are aromatized to estrogen on breast, endometrium, and cardiovascular system, and no consensus on definition of female androgen deficiency and cutoff level to define hypoandrogenism in female. And duration of testosterone therapy could be, the duration of studies is generally 3 to 12 months, and the long-term safety of testosterone therapy cannot be assured. Then dehydroepiandrosterone, DHEA, that is precursor of adrenal androgen. The DHEA supplementation improve sexual desire, arousal, and orgasm, possibly by conversion to testosterone, may have androgenic side effects like acne. Vaginal DHEA may reduce the systemic side effects and needs further studies on safety and efficacy. Then non-hormonal therapy like vaginal lubricants and phytoestrogens. Lifestyle changes like they have to reduce the stress, then they have to upgrade for the exercise, yoga, or other relaxation techniques or support groups, regular date night to spend 1 or 2 nights away from family responsibilities, and professionals do not carry your office to your bedroom. So improving body image like weight reduction, bariatric surgeries, and regular exercise programs, and also treating pelvic floor dysfunction. Then psychotherapy, cognitive behavioral therapy, treatment of underlying psychiatric problem. There is no problem in the mind or head of the woman. To focus on helping the women to identify and modify the culprit factors like maladaptive thoughts, unrealistic expectations, and inadequate erotic stimuli, substance abuse. So sex therapy, respect sex, that is educating women and male to remove the myths and misconceptions about the sex, and addressing cultural or religious concerns, assigning specific exercises for it. And also we can see like what we can do homework assignment of the couple, like detailed instruction about each step in given, and the feedback is collected regarding the progress, and also in stepwise manner each person gradually develop to know his or her sexually sensitive body areas as well, and only if the progress is satisfactory the couple will be guided to move the next step. So based on the terminology used by Masters of Johnson, non-genital sensate focus, then genital sensate focus, then vaginal containment. So sensate focus is stage 1, stage 2, stage 3, and 4. Partners touch each other, then partners touch each other's genitals, then mutual touching, then women on top. So sex therapy, as we see, implicit first permission, that the provider explicitly encourages a woman to discuss any sexual concerns or questions she may have, and validates her right to satisfying sexual function. Then limited information, the practitioner may educate the patient about sexual physiology or suggest educational resources such as literature, videos, or erotica. Then specific suggestions we have to give, like sensate focus exercises, masturbation, Kegel exercises, technical advice regarding sexual positions, and also use of lubricants or dilators. Then intensive therapy, as we see, may involve referral for individual or couple therapy to deal with long-standing conflicts. So pharmacotherapy, we can see fibrancyrin, bupropion, and buspirion, bromelatonide, and PDE5 inhibitors, ginseng, and yohimbine is also used. So relationship with new partner, as we see, actually I have seen in one movie like Kabhi Alvida Na Kehna movie, in that Rani Mukherjee has an extramarital affair. She has not having any interest towards her husband, that is Abhishek Bachchan. She was having the affair outside the marriage, like she was having the affair with the Shah Rukh Khan. So like that, where there is a marriage without love, there will be a love without marriage. So take home message, Low libido is underreported, under-evaluated, under-treated. Proper history taking will disclose the diagnosis in most cases. Problems in between two legs and problems in between 2 years. So both the partners should be seen together. Non-pharmacological interventions often work well. So treatment overall constitute sex therapy, correcting hormone imbalance, vaginal laser therapies, complementary therapies like guided imagery and meditation, sesame oil, stress reduction, diet modification, mechanical aids, psychotherapy, behavioral treatments, and education and communication. We have to bring up and conversation with the patient about their history, what all the problems they have faced, what all the feelings they have towards their partner. Are they being stimulated with their touch or voice or anything? If they are watching together an erotic video, are they being equally stimulated? Like that, all we have to ask for. And so thank you for patient listening. Thank you, ma'am. Thank you.
Thank you so much, Dr. Sama, for the wonderful deliberation. So I would like to invite the chairperson to have their comments. Pragati ma'am, will we start with you?
Yes, Dr. Shama has given really a very wonderful talk, and she has explained everything. But can you explain again the pheromones? What are pheromones?
Pheromones or some means they are the smell which is produced. They are the they are the specified smell which is produced from the partner, which are being attracted, means with that pheromones of opposite sex is attracted, and that smell is being that smell will be getting the other sex, means spouse or partner nearer to them. That are pheromones. It's a smell producing hormones.
Okay. Really, you have given wonderful talk.
Thank you, ma'am.
Yes, this topic was this topic was not so common, and really patients don't even tell anything about this. Even there are so many infertile couple. If we take the history properly, then they disclose all this.
Problem is that we never ask. That's why.
Yes,
We start asking, they will come out with so many things.
yes, we start doing investigations, and then if we go to the history properly, then we come to know that this is the problem. Even for 2 years have passed of marriage, and they are virgin. Sometimes lady is still virgin.
Yes.
Examination, we came to know that the hymen is intact, especially.
Yeah.
Pain. If pheromone is coming in the new in the TV also, na, that some intimate, etc.
Yes.
The other persons. The TV ads are there.
Yes.
Actually, when any such patients come, actually we don't go into that many times. Then when we ask for ovulation study, when I ask them to do such intimate relationship in one night, and the other day they were hesitating, we are not able to concentrate because it's the ovulation study and we need to do it. It's like an exam we are writing, and we are not able to come to the that much arousal, and it's not happening. Then they are taking again sildenafil, and they are being artificially aroused for that sometimes, because ovulation study, it's like they are writing some exam. So sometimes we have to means counsel them that it is a follicular study and they are doing this for themselves and for the baby, for upcoming baby. So most of the couples there, I felt they are losing interest, or they are tensed in that situation.
Yes.
Stress of the infertility is a very common thing.
Okay, thank you so much.
Garima ma'am, comments please.
I think she is not here.
Garima ma'am, your comments, please. Ma'am is there? No.
I don't think so. She
Amita
is
ma'am?
not here.
Yeah, Amita ma'am.
Yeah, very good talk. Shama, you had covered all the points. That is started from the definition to the take-home message. And you are vastly covered the hormonal changes and the hormone that affect on this. So it is very good and very informative talk. So thank you very much. So
Thank
we
you, ma'am.
are listening your talk very calmly, and each and every point you have taken, and that is the very good, very nice. And as Pragati ma'am said that this effect on the infertile couple, we are not taking the history. In my practice also, I got a couple, both are down, but they had educated, and one problem is between them that the female partner sister told her that it is a very painful process, and since last 2 years they can't contact. As soon as she go and before the arousal, she started crying and all this thing, and that's why she is infertile. As I console her and give that meditations for this, and I told her that you regularly practice this meditation and you concentrate on this. And thank to God, within 3 months she conceived, and now she got a male child, and it is also blessing of God that the child is not dumb.
Wow.
He is now 2.5 years old. So this psychological problem and this all affect very much. So we have start the sex education from the beginning, as we started the biology 8th or 9th classes. So if it is in the quorum study, but they are not so much open. So I think just we started to go to the girls' school, and I have taken 4 or 5 classes according to for this, and all the sex education, although it is not possible to give in the boys, because they had so many questions due to this media and all these things. So it is better to give the talk to the female. And thank you very much.
Thank you, ma'am.
Congratulations, Amita madam, to starting this sexuality education in school, because it is a very much needed, and it will clear so many.
Neeraj sir, your voice is very volume is very low. Can you just increase the volume?
No, my volume is full, but I think some net issue. Now you can hear?
Yes, sir. Now it's okay.
Okay. So Amita madam, I must congratulate you for starting this sexuality education in school, because it is a very much needed, and we also do some activities in school and colleges, because it will help our younger generation to overcome so many problems in the future. And one more thing is because in our Indian scenario, menopause is considered as an end of sex life. Gradually things are changing, but for majority of our Indians, it's like that. Once you are entered in menopause, your sex life is over. But it should not be like that. So we also have to consider those group also, our menopausal age group patient, to have a chat with them and to guide them about their sexual problems.
Thank you, sir. Thank you for
Thank you so much for wonderful interaction. Thank you so much, Sama, for wonderful topic, and the chairperson, Dr. Amita Singh ma'am, my wonderful Pragati ma'am. Thank you so much. So I would like to hand over to Madan sir to start the second talk of Dr. Monica ma'am. Over to you, Madan sir.
Yeah, thank you, Dr. Apurva. Yeah, we will proceed to the next talk, the title of which is Vaginismus. For that, I would like to invite chairpersons Dr. Samul Naim ma'am and Dr. Preeti Vaish ma'am. Dr. Samul Naim ma'am, who is a senior consultant, B.R. Khan Memorial Hospital, Aligarh, and Dr. Preeti Vaish ma'am, she is a senior consultant and president of Bareily OBGY Society. Welcome both, and I request you to start the session and invite the speaker. Thank you.
Thank you. Thank you for inviting me. And I'm loving to be a part of this interesting topic, which is neglected till date. And I will like to invite Dr. Monica Gupta. She is HOD and senior consultant, Daksh Hospital, Alwar. And she's also a president of Alwar Obstetrics and Gynecological Society. And there are so many other things, but I was asked to give the short introduction. So I will ask her to continue with this talk. Welcome, Dr. Monica.
Thank you, ma'am. Thank you for the kind introduction, for giving me this opportunity to speak on such a topic, good topic of vaginismus. As we all know, it is a just a 1 minute. I'm just sharing my screen first. It's a good topic of vaginismus because it is a nightmare for the couples. Because it is a psychosexual problem.
Your presentation.
Now, sir, it is visible.
Share your screen. No, ma'am, it's not visible.
It's not visible.
No, it is not visible.
You stop sharing and again share.
Okay, sir. I'll just do it again.
Apurva, do you have backup now?
Yeah, I have the backup, sir. If let ma'am thinks agar nahi hota hai, to I have the backup. I can share.
Okay, now it is visible.
What?
Now it is visible.
It is visible?
Wait.
Yeah.
Still not coming.
Is it visible or not?
Not yet.
Share all?
Wait for a few seconds. Just saying that it has started simple.
Network may be slow. Network
might
issue
be.
may be there. Yes,
Yeah.
now it's visible.
Now
Yes,
it is
it's visible now.
Is it visible?
Make it
Yes,
full
sir.
screen.
Yes. Ma'am, please make it full screen.
Full screen.
There is a button slideshow.
I think there is some network issue in that. It और छोटा हो गया.
Acha, ma'am, try to move the slides. Is it moving or not?
It's moving.
But
It's moving.
We can't see.
Okay. Yes.
It is in not full screen
It's
mode.
small. मैम सबसे नीचे वहां पर आता है ना. हाँ, आप वो करो, वो डमरू वाला जो है. Try to make it slides.
Now it is visible?
Yes. Now it's okay. Perfect.
It's fine?
Perfect.
Yes.
Sorry for these small technical problems we always face when we are doing the webinar. And I think everybody will cope up with that. Now I will start with my talk. I'm now going to talk about on the vaginismus. It's a nightmare for the couple because it is a psychosexual problem that is affecting the patient's psychological and sexual life, and many a times can lead to divorce. नहीं ये अटक रही है, सेकंड स्लाइड नहीं आ रही, हाँ नहीं सेकंड स्लाइड नहीं आ रही है, बहुत बहुत नीचे चली गई।
Second.
Vaginismus was first described by Dr. J. Madison Sims as reflex-like contraction of the circumvaginal musculature resulting in non-consummation of marriage. Later, the definition was given like recurrent or persistent involuntary spasm or constriction of the musculature surrounding the vaginal outlet and the outer third of the vagina that interferes with the vaginal penetration. In 2005, a new recent definition came from International Definition Committee, which states that persistent or recurrent difficulty of a woman to allow entry of a penis, a finger, or any object despite the woman expressed wish to do so. She is willing to do that, but she has an uncontrolled and involuntary contraction of the muscle which doesn't allow penetration of anything into her vagina. As we all know, female sexual dysfunction are described as female orgasmic disorder, female sexual interest and arousal disorder, which we have already discussed, and my third topic, which is into genital and pelvic penetration or pain disorder, which include dyspareunia, vaginismus, and non-coital sexual pain disorder. We all know exact prevalence is very difficult to know. It is not known because it is very difficult to assess. We can only assess during vaginal examination, and worldwide the incidence is 0.6 to 7%, and it can be as high as 17% into our practice because many of the patients are really afraid of going for a vaginal examination. It can be divided into primary and secondary. Primary is lifelong. She had never had an intercourse. And in secondary, as usual, is acquired later on in the life when, after having a proper intercourse, now because of some reason, either the sexual trauma or some disease process, she is not able to have penetration. Second classification is complete, partial, or situational. In complete, there's inability to place anything in the vagina, whether it's a finger, object, or penis. And in partial, it is permissive for few occasions. She can allow gynec examination, tampon insertion, but she can't have an intercourse. Or in situational, when in few situations, she can have vaginismus, and if we avoid those situations, she can have a normal intercourse. It include non-organic as well as organic causes. Non-organic causes include psychosomatic disorder, phobia, conversion syndrome, and vaginismus is the expression of the body of the psychological fear, what she feels for the penetration. She can be fearful for the pregnancy, HIV, AIDS, or some other disease. That's why there's an involuntary contraction of the muscles. It can be secondary to fear and anxiety, and it is a defense mechanism of the body. Patient can have negative perspective for the sex. She can have religious orthodoxy. She feels it is shameful. She feels guilty of doing sex. She feels this is a punishment what she is getting out of marriage. She can be discussed regarding genitalia. She can have homosexual orientation, or many a times it is a taboo to talk about sex, and few patients, they have a knowledge that it is going to cause severe pain, injury, or bleeding, what they get from some other media or something like that. And now they are in so much of the fear, they want to avoid intercourse at any cost. Usually, the patient have history of sexual abuse in young age, whether it is a sexual trauma or a rape, and that can lead to vaginismus in later life. Organic causes include lesions of external genitalia, and because to prevent the pain, the patient is having natural protective reflex as vaginismus. There can be a hymenal abnormalities, STD, genital herpes, warts, thrush, obstetric trauma, or mechanical injury caused by the painful scar. Whenever there's some penetration, there's a pain, so she wants to avoid that. Endometriosis, post-radiation therapy, Atrophic vaginitis in the postmenopausal woman because of estrogen deficiency can lead to less lubrication. So there is a pain, and to avoid that pain, patient can have vaginismus in later life. There can be pudendal neuralgia, pelvic inflammatory disease, pelvic organ prolapse, vaginal lesion, tumor, malignancy, comorbidity like diabetes, multiple sclerosis, spinal cord injury, and these all lead to either pain, poor lubrication, or insufficient expansion of the vagina, which is the cause for vaginismus. Many a times, pelvic floor muscles are which are indirectly innervated by the limbic system. So whenever the patient is under emotional stress, the involuntary contraction of the muscles occur, and patient can have vaginismus. Now we should discuss what muscles are involved in the vaginismus. We all know it is the lower 1/3 of the vaginal muscles which are involved, and the most important one is bulbocavernosus muscle, along with levator ani, pubococcygeus, and perivaginal muscles. So whenever these muscles contract, there is inability for penetration. Likewise, grading was done by Lament in 1978. While doing a vaginal examination, he graded into the 4th grade, and later on 5th grade was added by Passig. They are depending on the severity of the cases. In grade 1, when we are doing an examination, there's a slight contraction of the levator ani muscle, and when we counsel her and she relaxes, we can do a vaginal examination. In grade 2, when we are doing the vaginal examination, the contraction of the muscle is there, but we are able to do the vaginal examination. In grade 3, patient wants to avoid it by elevating the buttock, and it is a severe form of vaginismus. In grade 4, she elevates the buttock, retracts and uptakes her thigh, dorsal arching is there, and she wants to avoid vaginal examination as possible. Grade 5 is the severest one given by Passig. In this, patient attacks the doctor. She wants to avoid it, vaginal examination at every cost. She jumps from the table. She starts shouting, trembling, shaking, and whatever she can do to avoid examination, she will do it. How the patient presents to us? They are mostly present as non-consummation of marriage. They can tell us, directly come to us, telling that they are not able to do an intercourse. Or when we are sitting in a sexual dysfunctional clinic, and many a times we diagnose these patients in the simple gynec clinic when they are coming for some other gynecological complaints. And to our surprise, many patients come for the IVF because they are having vaginismus and they are not able to do a proper intercourse. How it is going to affect the patient's life? It is a personal distress to the patient as well as to her partner, which can even lead to erectile dysfunction and premature ejaculation in the other partner. It is an anxiety disorder. It can lead to dyspareunia, and all these things, they affect the interpersonal relationship, their bonding, and may lead to a divorce. How we are going to diagnose it? It is diagnosed by careful history and unhurried methodical examination if patient allows us to do. We should make the patient comfortable. We should gain her confidence. We should never be judgmental to her, and we should give plenty of time to her so that she becomes comfortable. She will only then she will allow us to do an examination. While doing consultation, what important thing we should know? We should acknowledge her. We should give her proper respect. We should listen her. Our body language should be such that she feels that we are interested in her. We are with her. We should never make her feel that we are avoiding her by any means. We should be having respect, empathy, and genuineness, and should have a very good communication skill. When we are evaluating what things we should ask about the concept and beliefs and what influences vaginismus, what are her expectations, what is her phobia, why she is having fear of either pain, pregnancy, or HIV or AIDS, what is her family background, what is her religious thinking, is she think that sex is wrong, we should not do it, and is it a punishment for her, is she feel guilty doing it, Even though the patient are highly educated, their sex knowledge is poor. So we should motivate them, we should sex counsel them. Many a time, the cases of post-traumatic sexual experience, the history of sexual abuse or rape in the earlier life can lead to vaginismus. We should ask about that. Domestic and social reason, what is her sleep pattern, what is her stress level in the work, financial or overall life stress, what is her sexual experience in the previous marriage, why, if she is having divorce, why, what was the reason for divorce, if she has undergone some kind of domestic violence or sexual violence. The most important things to ask about the how is her bonding with her partners. Is the marriage done against her wish? If she is happy with it, how she, is there any lack of affection, fear of rejection, is there any performance pressure doing a sexual intercourse? And in the cases of situational cases, we should know what situation leads to vaginismus, and if we possible, we should modify that. In the medicine abuse, patient is taking anaphordiasic drugs which inhibit sexual desire, can also lead to vaginismus. Some type of pain, especially musculo-orthopedic pain, can also lead to this type of problem. When we are taking sexual history, we should ask about her sexual orientation, her feeling, whether there is a consummation or non-consummation of marriage, what is the frequency, desire, initiation of the sex, what are the erotic thought, is there, she is interested in her, is there any performance pressure, is the lubrication proper while doing a sex, is she having same experience with the other partner, if she has or not, what type of foreplay they go, what type of sexual activity they indulge, is there any masturbation practice they involve. We can ask about the female sexual function index questionnaire or Glomberg-Rust inventory of sexual satisfaction. When we ask these questionnaires, we can decide what type of problem she can have. We can evaluate for the chronic diseases like diabetes, hypertension, renal, liver disorder, cardiac abnormality. Endocrinal problems are very common. Thyroid, FSH, LH, prolactin, testosterone should be tested. Gynecological examination should be done only when the patient is ready for it and patient allows us willingly. We should always see for pain triggering spot in vagina or vestibule, as in the case of vulvodynia or vestibulodynia. Is there any post-surgical or post-infective scar like of episiotomy, Bartholin cystectomy, or any other infective disease? We can examine for dryness, atrophy, lichen sclerosis, thrush, etc. We should know about the muscle tone. If she allows, we can go for a speculum as well as digital examination. In cases of secondary vaginismus, deep dyspareunia is the most important cause because of endometriosis, PID, adenomyosis, hypertonic pelvic floor exercises, etc. Psychological and psychiatric conditions also lead to this problem, like stress, anxiety, depression, when the personality type is OCD, narcissistic, anger disorder, likewise. When we go for the differential diagnosis, it can be vestibulodynia, vulvodynia, or deep dyspareunia. Whenever the most important part is treatment, because patient really is fed up with this problem, the couple really want to get treated, and we should assure them the condition is treatable. We are getting plenty of methods to treat you, and you will be definitely relieved. Only when she has confidence in us, she will allow us to treat. We should try to involve couple in the treatment. Sex education should be done, counseling, lubricant, anesthetic cream, xylocaine jelly to alleviate pain can be used, pelvic floor exercises, systemic vaginal desensitization using dilators, fingers, or special instrument can be used, pharmacotherapy including anxiolytic, physical therapy with or without biofeedback can be used, psychotherapy, hypnotherapy, cognitive behavioral therapy. Sex therapy, synate focus is important, what we have already discussed. And recently, the most important one is the Botox use. Desensitization using the dilator or vaginal or the fingers can be done. And the control trial says it is very effective in the mild form of disease. Dilators are available in different materials like plastic, silicone, or glass in different sizes from 19 to 35 centimeter. We should educate the patient how to use a dilator, and first sitting should preferably be in the anesthesia so that she won't feel pain and she feel confidence. This type of up to this dilatation I can do, and she gradually do the dilatation. We can start with her own ring finger because the patient won't feel it is a foreign body. She will allow her. Later on, we can increase the size of the finger from little to the index, middle, likewise, and later on the husband's finger can be used so that she will not feel fear when something is penetrating into the vagina. Later on, intercourse can be allowed. And when we are telling her to do it, we should always, there should be a proper lubrication before doing the dilatation, and she should prevent infection. Aseptic condition should be there. And these different type of dilators are available on the internet. She can use her own for doing the dilatation. In the severe cases, even after doing dilatation for 1 year, the patient is not going to get relief. So we should use some other methods along with it to relieve the patient symptoms. Pharmacotherapy include anxiolytic as well as antidepressant drugs. They can allay the anxiety of the patient, fear, and the patient can be relieved of vaginismus. Sex counseling is very important. It improves the communication skill, dominate compromise libido, reduce anxiety, depression. It is useful only in the cases of less severe cases, or it can be used along with other procedures like desensitization or Botox therapy. Senate therapy, Senate focus therapy, what we have discussed is the therapy of touching and is being touched. The patient attendant allowed to touch different part of the body, but they are not allowed to do intercourse. So the fear of the foreign body is elevated, and many a times the vaginismus is relieved in the mild cases. Psychotherapy and hypnotherapy include cognitive behavioral therapy. The patient understands the thought and the feeling and the behavior that helps reclaim the fear of penetration and avoidance behavior, and gradually they are exposed to intercourse using cognitive behavioral therapy, and because of the decreased fear and the pain. In hypnotherapy, verbal interaction is done. We find out what is the cause for vaginismus and we try to avoid that. Now the most important one is the Botox therapy. It is a heat labile neurotoxin that is derived from Clostridium botulinum. It is the most lethal substance because it causes flaccid paralysis of the muscle. Usually the type A is studied and it exists in 8 forms from A to H. And its effect is seen from 7 to 10 days and it lasts for 3 to 9 months. The toxic dose is very high, from 40 units per kg body weight, and the therapeutic dose is low, from 20 to 200 units. Usually we use around 50 to 100 to 150 units in the cases, and the contraindications are myasthenia gravis, Lambert-Eaton syndrome, and other muscular disorder, and the person who are allergic to albumin in the pregnant as well as lactating women. How we are going to inject it? Better we should do in the anesthesia because the patient is having fear of something coming to her body. She will not relax and we can miss the point where we want to inject. They are available in 2 types, Botox or Diprost. Botox is 2.5 times potent than the Diprost. We should inject in the lateral wall of the puborectalis muscles, and if we want draw an imaginary clock at the introitus, we should avoid the area from 11 to 1 and from 5 to 7 because they are included anal and well as urethral stricture, and if the muscles of that area are paralyzed, they can lead to incontinence that is going to make the patient suffer more. So it is easier, we insert a Simpson speculum into the vagina that will block that area, and in the lateral wall with the insulin syringe, we can inject the drug. What are the adverse effects? Is the side if the site is not appropriate, that can lead to anal as well as urinary incontinence. They can lead to excessive vaginal dryness, and there can be a failure rate requiring repeat injections. And Pasik gave a multimodal program. In this, he used 100 to 150 unit of onabotulinum toxin A along with 20 to 30 ml of bupivacaine with epinephrine. Treatment of the partner is also important because of the continuous resistance from the female partner. Male can have erection dysfunction or premature ejaculation. So if he's having some problem, we should also treat him. In cases of organic diseases like vulvar vestibular syndrome, vaginitis, urethritis, cystitis, we should treat them. For endometriosis, we can treat by hormonal therapy, pain management, etc. And the vaginismus is a common in last, my take-home message is vaginismus is a common sexual dysfunction which we should diagnose in our clinic, and its actual prevalence is very high. What is given in the books, and it is going to affect the couple relationship. We should go for a proper evaluation, diagnosis, and we should do a proper differential diagnosis. We want now know what is the severity of vaginismus. Only then we can plan what treatment is suitable for her, because the patience is very less, and we should be very effective in doing that. We can use 2 or more therapies together. Botulinum toxin is a very good choice, but we are still waiting for more effective treatment to come. Researches are going on. And when we can do something for her, why she should suffer in silence? We should treat her, we should give her wings and let her fly, let her enjoy her life. Thank you very much.
Thank you, ma'am.
Sorry to interrupt, Preeti ma'am. Our guest of honor for today, Dr. Yashudhara ma'am is here.
Yeah.
So
Yeah.
we will first welcome and getting the blessings from the ma'am, and then we will proceed. Sorry
Welcome,
to interrupt.
ma'am.
So really thankful to ma'am. Thank you so much, ma'am. Ma'am doesn't need any introduction. Ma'am is such a senior and at present vice president, Foxy. She is being the immediate past president of the Lucknow Society. So thank you so much, ma'am, for giving us the time in your such a busy schedule. And thank you so much, ma'am. Welcome you. And we are really eagerly waiting to get your blessings. Over to you, ma'am. Yashudhara ma'am.
First of all, I'll say that good evening to everyone, and one sec. Yes. Good evening to everyone, and sorry for joining late. That time, 5 o'clock, there was an inauguration of, I am in the Yatra of the President Pai.
Yes.
You all know that now our Foxy president is Dr. Rishikesh Pai and Dr. Madhvi Patel, General Secretary. Both of them were in the inauguration. I was also with the inauguration, and there's a member of parliament was talking. So it was not possible to get up from that and come here. So I'm so sorry that I joined.
You joined in such a busy schedule, and in between the program, that is really our fortune that you are here, ma'am. So really, ma'am.
So first of all, I would like to congratulate Dr. Neeraj Jadhav, a chairperson, Sexual Medicine Committee. This is one of the problem which people were silently suffering, but not coming to you. With Dr. Neeraj has done wonders for this society. People must be thinking that there's nothing in this society, but you can see what Dr. Neeraj has done with the help of Dr. Apurva Datta and Dr. Madan. He has really brought the subject which was very hidden, not talked about it. In fact, in the infertility specialist, because I practice not a IVF, but I practice lot of infertility. So people do not ask about these infertile women, whether do you have a right intercourse or not. They have got so many erectile dysfunctions, impotency, but the women do not talk because the doctor do not ask. If you ask, they come out, and there's a treatment for it. They don't have to go anywhere else for getting pregnant. Because they are not having azoospermia. It is not necessary they are azoospermic. So at least if you cannot do any surgery for them, of course it is all available, but at least that woman will be out of that stigma that she cannot produce, or she has to go to still some quacks, or sometimes she has to get a donor insemination, which is when she can have the biological father and the mother. So then I was just listening to Dr. Monica. She has also brought a very good subject, because these are the things, as the longevity is increasing, the demand is increasing. The people and in the initial days, probably there is a crunch for the money also. But once you enter into a midlife, probably you want a quality of life, because your children are settled. Even they do not want your money, whatever you have. They want you should remain happy and healthy, so they can also remain happy and healthy. That is what they want. So it's very essential that one should have a quality of life. And this all is very, very necessary. Sexual education is a very, very important part of it. I have seen people living together for years together with the non-canalized vagina, but because of the constant force, it has become patulous. They did not know what is the penetration, neither the man nor the woman. And they're just suffering. And then somebody has referred to us for the ultrasound because of some problem. I do not remember. And I tried to put a vaginal probe because it was it was a married couple for 10 years or something. I could not insinuate the transvaginal probe. Then I just looked into it. And then I saw this is the story. So these are the problems which are not talked, but with the effort of Dr. Neeraj and doing so many webinars, this time he has joined with the many societies of Mau. Dr. Kusum Verma is there, and Dr. Garima Tyagi is there. I just met her with Khora Makhanpur Society, Dr. Garima, and Dr. Pragya is there, Dr. Asha Singh is there, Dr. Neeti is there, Dr. Ambar is there. So it's a Jaunpur Society, Mau Society, and probably it's a Aligarh, Dr. Seema Hakim. So Aligarh, Bareily, Jaunpur, Mau, and Khora Makhanpur. So I said, Garima Tyagi, I met in the Khora Makhanpur just now in this yatra, because we are traveling from Rishikesh to Dehradun to Khora Makhanpur to Meerut, Aligarh, Agra, Kanpur, Gorakhpur, Lucknow. Yesterday we were in Prayagraj, and today we are here, and we are finishing. So we are coming to Mau. Mau is also there, Bareilly. So I really congratulate all the president and secretaries of these societies to be part of this society, to be part of this sexual medical education webinar. And I'm sure you all are, Dr. Neeraj is going to come as a vice president next year, or I'm sure, Dr. Neeraj, you are going to finish in 2023 or 24?
24.
24. So you are coming in 25 election for this thing. Yes. So you all should remember him, and my best wishes to Dr. Neeraj for all his efforts, what he has made. He is a very dynamic person. Thank you so much for making me a part of it and giving me a chance to it. Thank you so much. Sambul, Dr. Sambul, I could see Dr. Sambul.
Hi.
Yeah, and I could see Dr. Anita Singh, Anju Kanojia, Asha Rathi, to I know, Asha ji, many times we have met, that Mala Mittal, and Madan Kamble is in the organization. Madan is in the organization. So I'm sure that we are all going to meet in the AICOG also. Dr. Namrata Bhardwaj and Dr. Shama Sultana. So my best wishes to all of you. Thank you so much.
Thank you, madam.
Ma'am.
Purva,
Thank you
Kusum
so
Verma
much,
madam is
ma'am.
there, I think. You can invite her, Kusum Verma madam.
Yeah. Ma'am, yeah, sir, we already get blessings from Kusum ma'am.
Okay. Sorry, sir, one was missing. Okay. Okay, go ahead.
We have 3. Yeah. Madan sir, so we can proceed with the session. Yeah.
So may I get a permission to leave this?
Yes, madam. Thank you for joining.
Yeah, thank you so much.
Thank you so much,
I
ma'am,
really
for
want to
giving us
listen to this webinar because it's very informative and it helps you while you're teaching your patients.
We will
But
send
I'm
you
so
record.
sorry.
We will send you recording, madam.
Yes, thank you so much, Neeraj. Thank you so much. You are such a nice person. My best wishes
Thank
to
you
you
so much,
for your-
ma'am, for your coming, for your blessings, ma'am. Thank you so much.
Thank you so much.
Yes, we will proceed.
Madan, just chairperson's comments.
Yes.
Yeah.
Yeah. I would like to request Preeti ma'am and Sambul ma'am to give their comments regarding the Monica ma'am's talk.
Yeah, thank you, Dr. Madan. Actually, it was a nice talk, but as Dr. Monica said that it's difficult to have exact data of sexual problems, but it is not uncommon. But least talked about because we are being judgmental most of the time. We are listening less to the patients, and referral is the easy option. So we should give some time, especially in infertile couple. As ma'am said, that it is very common that they don't know actually what the act is, and they are not conceiving and they're going for hi-fi treatments. And this can be solved with the simple counseling and proper examination of the couple. So it's very important topic, and I'm happy that Dr. Neeraj is taking care of it, and Dr. Monica covered it so nicely that I don't think that any point left for further consideration. Thank you.
Yes, thank you, ma'am. Is there Preeti ma'am?
हाँ, डॉक्टर मोनिका ने बहुत ही अच्छे से कवर किया पूरा टॉपिक, बहुत ही अच्छा लगा. हम लोग अक्सर पेशेंट्स की इन प्रॉब्लम्स को ठीक से सुनते नहीं हैं, ना ही उनकी प्रॉब्लम्स को कवर करते हैं, और इसलिए इनफर्टिलिटी में कई बार हम लोग देखते ही नहीं है कि पेशेंट की क्या प्रॉब्लम है. बट डॉक्टर मोनिका बहुत ही अच्छे से कवर किया अपने वेजिनिस्मस को.
Thank you, ma'am. Thank you very much.
Thank you so much, Dr. Monica.
Thank you, ma'am. Thank you for the appreciation.
Madam, होता क्या है कि most of the time when patient of vaginismus come, we write lubricants blindly. We don't take proper history. We don't give time. So most of the time, it is the fear is the main issue. So once we start taking proper history and examination, we can solve many issues.
Yeah, thank you.
Can I add one point?
Padmini madam, yes.
Yes.
मोनिका जी ने बहुत ही अच्छे से कवर किया है. Thank you so much.
Thank you, ma'am. Thank you.
Yes,
one of the common things which I have seen or observed in patients of vaginismus is this is the easiest way. Many gynecologists just do one hymenectomy and leave at that. They think because the husband complains the penetration is not possible, it's very tight. So immediately they do one hymenectomy and send them. So hymenectomy should be the last thing in vaginismus. Unless you treat vaginismus, unless there is a real rigid hymen or narrow introitus, it should never be done. And the vaginismus is the first thing. I always tell them whether the door is this big or this big, if it is closing, the effect is same. So that should be the thing. And some of the severe cases of vaginismus is very difficult to treat, and it may take little time, but with lot of patience and with proper counseling, self-dilatation, and the usage of the dilators, relaxation techniques, everything put together, it has to be treated. So I treat vaginismus, not less than 3-4 cases of vaginismus I get every weekend. So especially it is highly common in educated class. So to say, I have not seen much in less educated class or the rural people, but it is more common in the urban people and educated and highly placed people. That's what. And the other thing which I have observed is that the advice of the local anesthetic application, because see, they should be aware of the sensation. They need the sensation, genital sensation. Don't anesthetize the sensations. So that is another thing which I wanted to add. Thank you.
Thank you, madam,
Yeah.
for your nice comments and
Sometimes
Yes, madam.
Sometimes with painkillers.
Madam, your voice is echoing.
Yeah. I'm on the mobile.
There are
You are on 2 devices.
Yeah.
So that's why it is echoing. Close one device.
I'm saying sometimes the painkillers and even the mild sedation works to avoid the vaginismus.
Madam, can you switch off one device, because you are on 2 devices, that's why it is echoing. Unmute yourself, madam. Asa madam, unmute.
Hello. Sometimes the
ma'am.
painkillers
Ma'am.
and also some sedation works to avoid the vaginismus.
unless there is dyspareunia, painkiller won't help usually. So if there is associated dyspareunia, it may help. But pure cases of vaginismus, usually painkillers will not have much of a role there.
Madam, in cases of secondary vaginismus because of some painful scar like episiotomy or Bartholin cyst or some infected cyst, we can a little bit help can be done with the painkillers.
And treat
Only
the
in
cause,
those cases.
treat the cause, excise the scar, and see they do the thing. Whatever that is causing, the root cause for the vaginismus can be treated, and some amount of painkillers can be given.
Thank you, ma'am. I would like to request to take over Dr. Apurva sir for next session.
Yeah, sure. So after this wonderful session and wonderful discussion, now I'm moving to the third talk. And for chairing this session, I would like to invite two very senior Dr. Anju Kanojia ma'am. Ma'am is the consultant at Ashirwad Hospital, Jaunpur, and she is the clinical secretary, Jaunpur Yoga Society. Thank you so much, ma'am. Welcome, ma'am, for accepting our invitation. And second is Dr. Mala Mittal, ma'am. Ma'am is the senior consultant at Mittal Nursing Home and ex-past secretary, Mau Society, and at present the clinical secretary of the Mau Society. So welcome, ma'am. Thank you so much, ma'am. Over to Mala, ma'am, to introduce our speaker, Dr. Padmini Prasad, ma'am. Yeah.
Good evening, everyone. Hello. Good evening.
Good evening.
Am I audible?
Yes, madam. Yes, madam.
Thank you for.
Yes, ma'am. You are audible.
Okay. Thank you for inviting me. Dr. Padmini Prasad. She's consultant obstetrics and gynae, and she's first qualified women sexologist from Karnataka. She's medical director, Ramamani Nursing and Maternity Home, Institute of Sexual Medicine, Bengaluru. She's past president, Bangalore Society of Obs and Gynecology Society, 2021-2022. She's author of 11 books on sexual and reproductive health in Kannada and English. She's member of World Association for Sexual Health. She's founder, president, Bharvasa Charitable Foundation, Reach the Unreached, Speak the Unspoken. So here I invite Dr. Padmini Prasad to come and give her talk. Please, Dr. Padmini Prasad.
Good evening to you all. Thank you very much for the nice introduction. At the outset, I would like to thank the chairperson, Dr. Neeraj Jadhav, who is really sensitizing our gynecologists, creating awareness and giving so much of importance that whatever that was due for this subject, and really congratulate him. I thank all the participating societies of Uttar Pradesh who have given me this opportunity and invited me to talk about this. Before that, I would like to share screen. Yeah. So till now, you could listen to so many aspects of sexuality and the various problems which can occur, and how difficult it is sometimes to know that the woman is suffering from the sexual dysfunction. And unless it is made, the history is made a part of overall history, and it is extremely difficult to know whether the woman is suffering from any sexual disorder or dysfunction or difficulty at all. Because it is not like that the woman will come and tell, I have got fever, I have got cough, cold, and she won't come and tell, I have got desire disorder, I have got orgasmic disorder. She will tell it in an indirect way, and also she can so many times they can use the colloquial language and also the slang languages. So it becomes, unless you are familiar with so many aspects of the sexuality and the sexual health, it may be extremely difficult to know what exactly it is. Like in any other subject or any other disease, and history taking is the most important thing to diagnose, to evaluate, and give the proper treatment. Unless there is a proper history, most of the diagnosis in sexual health can be made by just taking a proper sexual history. So as the gynecologist is the first point of contact for any woman, for the couple or to the family. So history taking and the sexual history should be a part of overall history. Anything, right from any disease, medication, or surgery, operation, psychosexual, psychiatric problems, psychological disturbances, or even just a simple day-to-day stresses, and also the interpersonal relationship can have a lot of bearing on sexual health. If your sexual health is an important aspect of quality of life. So sexuality and sexual health are very important when you are considering the quality of health of a woman. So that's why let me just take you through and tell how important it is, how you can arrive at a diagnosis, how the patients can present to you with a sexual history. So unless you have all this in your mind, sometimes it may be very difficult to understand things. So history taking in sexual medicine. First of all, you should break the silence. You should let us talk about sexuality. That's what we are doing, and that's what Dr. Neeraj Jadhav is doing, and involving almost all the societies in all over India, and just to break the silence and tell the importance of sexuality. So let us talk sex. Even till today, even the politicians and the government is still not convinced about proper healthy sexuality education right from young age in schools and colleges. Still they think they equate sex to sexuality education as intercourse education, and they think we spoil the children by giving them wrong information, and children can experiment unless they know what exactly is sexuality and what exactly is taught to the children. And unless that is known, it becomes very difficult to convince them. So many doctors are usually concerned when they are taking the history about the ability to take appropriate history in case of sexual problem. The patient and the doctor are embarrassed and uncomfortable. Patient may feel ashamed or even humiliated to ask for help with a sexual problem. So if you trivialize things, and first of all, you should accept and you should tell them, you should normalize her problem, if at all, if she tell, not laugh at her or show a bad body language. So the doctor himself or herself should be very much, should be comfortable with her own sexuality, first of all. So patients should not feel ashamed or humiliated. And sometimes the hospitals just give the pre-consultation questionnaire without even telling them what it is and how they have to go about it. So they may even feel, if you just give a sexual questionnaire in the outpatient or the waiting area, they themselves, they may feel embarrassed, thinking that people around may be knowing about that. So it may become an embarrassing situation. And the main important thing is sex is a taboo. Though, of course, people have become comfortable of late over the past few years with so much of awareness in the media and both the print and the visual media, still the sex is a taboo topic in the society. The terminology or the usage of words is the main problem. Even today, we don't use a proper terminology for the genitals. When the children, even with the children at home, we don't use proper names like penis, vagina, or the genital, or the urinary passage, or anal passage. So all possible other languages or other terms will be given to the genitalia. So when the child is disturbed, or if there is infection, if there is sexual abuse, the child or the person will not know how to explain. So many times they come, I have got pain in my kidney. What they are telling is the pain in the genitalia. So that is how they have got their own way of using that. And it is not taught in medical colleges. This is the most important thing. You all know, whether at undergraduate level or at the postgraduate level, the sexual medicine is not taught. We may learn about anatomy and some hormones or some the genital organs, internal, external genitalia, the conception and pregnancy, childbirth, everything, but not exactly the path which has led to the pregnancy, childbirth. So the doctor must put the patient at ease. Certain aspects, and the previous speaker also was talking about how you have to be with the patient and how you have to put the patient at ease. And you should, when you find out the real problem, discover patient's background, take proper clinical history, then work out a plan of management. And you have to avoid embarrassment, allow sufficient time for the patient. And attitude, you should not call them as patient. It is just a client, you can say, because it may not be a disease in so many times. It may not be a disease. It may be just a disturbance or improper sexual life. So the attitude should be matter of fact. And the main important thing is doctor to be non-judgmental. You have to greet the patient. Patient should be seated very comfortably, because the client herself should have some of the rights of her own thing. So like how the doctor has got the rights, and the patient should also have the rights, privacy, comfort, and you have to observe the patient's body language, put her at ease. That even she is comfortable and moving her fingers, staring somewhere else, looking at the ceiling or at the door. First, put her at ease and tell her it is very normal to have some problems with the sexual relationship. If at all, if there is anything, you can please tell to me, and let me see whether how I can help you. And the confidentiality is extremely important. The person taking the history, as I was talking to you, it should be comfortable, knowledgeable. You should have at least some amount of knowledge about this, what can cause these sexual problems, and how you have to go about it in a non-embarrassing, non-judgmental way, and the terminology. And when you open the consultation, first of all, introduce yourself, you are so-and-so. And when you are talking to them, first thing you ask her name, make her comfortable, talk some other non-threatening questions. So they start becoming comfortable, and then they relax and they start telling about that. So confirm the patient's details and explain to her what you want from the patient. After taking the history, at the closing the consultation also is important. You have to summarize the history. Ask if the patient has any questions. You can tell whether is there anything else that you want to tell, and reaffirm confidentiality, and then thank the patient. And as I was describing it to you, so anything, any disease, surgery, or a relationship problem, or a medication can cause sexual problem. So when you are making sexual history part of overall history, you should also use your discretion when to use, when. So you can also end up in an embarrassing situation like this. A patient went and told his friend, I went to the doctor for a common cold and he asked me all about my sex life. I will never go to him again. You can see the furious face in this. So like any other disease, these are the various types of history which we get into: past history, personal history, family history, medical history, surgical, obstetrical history, sexual history, and relationship history. So any of these things can have a bearing to the present sexual problem. So in the family history, again, the fathers and mothers relationship, how they are, if there is a good family background and if there is a proper upbringing with a good values, and they also will learn good values about whatever it is, even whether it is sexual life or otherwise, they will have the good values, and how whether there is a parental dominance, and if there is a male dominance, and sometimes the woman is suppressed, and if the child is looking at this all throughout the life, then when it grows up, it will think, he is a man, he has to dominate on wife, and so he can also indulge in the sexual abuse or the poor interpersonal relationship. So all these things, whether how was the family, whether very orthodox family, and I had one patient from a very orthodox family in non-consummated marriage, and 5 years married, and they come for infertility. So when I took the history, and so they said that even the wife was not so knowledgeable, and the husband also, his knowledge of sexual intercourse was very poor. And when I explained to him what they're supposed to do, how they have to go about it, and really that it is a real incidence, that man, he fainted in the chair, and I had to get up and lift him and then put him at ease. And so just to know that there is something like that, and the sexual intercourse, that they have to interact with the woman to have a proper sexual life, which can lead to pregnancy. So there can be some of, and have got so many anejaculation problems, so many cases when they come for these infertility cases, and sometimes they I am not getting any discharge. The husband, wife also complains the discharge does not come. That means to say, so he is not ejaculating. And this is, I have seen quite a few cases of the anejaculation who have come from a very orthodox family, because conserving semen is very important and they should not lose semen, and so many misconceptions associated with semen. So that itself can give a clue whether it is a strict upbringing or a open type of family. And as sex games as children, it's a very common to handle the genitalia or touch each other's genitalia when they are children. And if they're punished for that, so from that time, the negative attitude is put into the children. And when they grow up, they think, so it is a thing which they should not talk about or they should not touch, and it is a dirty thing. So these are all negative things which they put right from childhood. And if there is any homosexual experience, and so many of these college students or students will come and tell, so I think I have become homosexual. And why do you think like that? Because I was misused, and when we were in hostel, we were doing so many the games we were playing, and we have had a homosexual relationship. So I think I have become homosexual. Just by having a homosexual experience, the person will not become homosexual. The orientation is entirely different. This is just a chance, and the experimentation are some boys when they do as youngsters. So how are the siblings and how are their attitude? In the past history, again, this whether there is any other disease and suffering from the tuberculosis or liver kidney disease. And most important thing is about sexual abuse, because there's a child sexual abuse is very common so many times, but at that time they will not know that something had happened. But when they grow up, they think that something bad had happened when they were children. And with that, they develop negative attitude towards sex, and sometimes that itself can lead to non-consummated marriages. And the medications or any previous marriage, because these days it is very common remarriage, widow marriage, and so second, third time marriage, all these divorces are extremely common. So you should also ask about the experience in the previous marriage. And the psychiatric history, you can very well know whether there is any anxiety, depression, some suicidal ideas, sad mood, crying spells. And looking at the person, if he is expressing all these things, then you can think that there may be something wrong with that in there may be some psychiatric history also. So coming to this personal history, the diet, whether they, because of a bad diet or a non-balanced diet and the junk diet, so obesity itself can lead to so many sexual problems, and obesity and associated medical disorders. It is extremely important to know the diet and the exercise, whether the person is doing exercise, whether keeping himself healthy, and the health of the muscles and his overall body health, and sleep, stress, work. And this is very, very important, because if there is, unless they don't balance, if there is no work and family balance, and if they are not combating the stress with the, you can see that the lady working the whole day, working for long hours, and especially with the demanding work in the computer IT/BT sector, so they will not have time to take rest also, no time for sleep. So when they come home exhausted from morning 6 a.m. to night 9 a.m. continuously working, so only thing they want is to sleep off. So then that becomes one of the reasons for the decreased desire, and also some of the sexual problems, erectile dysfunction, and so many other things. So medical history, it's very, diabetes, more than 60% of the diabetics are suffering from sexual dysfunctions, especially in the male, erectile dysfunction or ejaculatory dysfunction, and even in the female, the improper arousal, and also recurrent genital infections. And because of these things, she can develop decreased desire, dyspareunia, all these problems. So history of diabetes, the heart disease, hormonal problems, the thyroid, if there is hypothyroid, that can lead to decreased libido. Again, increased prolactin can lead to decreased libido. And commonly used drugs, they also can have its effect on the sexual desire or arousal. The surgical history and the past surgeries which are there, and surgeries, and in the hysterectomy and the surgeries on the vulva, vagina, or urethra, pelvis, it can disturb the blood supply, it can disturb the erectile tissue, and also disturb the nerve supply, so which can lead to decreased arousal, dyspareunia. And if there are presence of scars, you can know that it can indirectly, in the previous talk, you listen to that, the dyspareunia or vaginismus. So painful scars is one of the reasons for sexual dysfunction. And in the obstetric history, so many times you will be asked during pregnancy how you have to, whether you can have your sexual intercourse, or how many times you can have, how frequently you can have, whether you can have at all, and which month is safer for the. So all these things you should have some amount of knowledge to advise to the patient during pregnancy, post-delivery. And if they're especially in infertility, bad obstetric history, they will be suffering from lot of decreased libido and arousal problems, and not enjoying the relationship. When they're infertile, and you will be telling them at this hour, the timed intercourse, you go and have intercourse at this hour. This timed intercourse is extremely difficult thing, and so many times it leads to performance anxiety for the man, leading to erectile dysfunction and ejaculatory dysfunction. And so many times they will not have had any sexual intercourse at that time at all. So they simply say that they are having normal sexual relationship. So you have to get into the depth of that. And sexual history is the most important history after all the other histories. It's a number of years of marriage, consummation or non-consummation. Whether it is so many times they don't even understand, have you consummated the marriage? If you ask, then they say yes, and later they ask what it is. So that's all. When you clearly explain, whether you ask the woman whether she is feeling the feel of penetration is there, whether it is entering the vagina, or whether it is not, she is not unable to enjoy the sexual relationship, or whether the husband is able to penetrate. So in-depth questions should be there. And what was the experience of the first night? Because most of this time, the first night is glorified. And in the media, these magazines and the movies, so they think the first night they have to be like this only. So they should enjoy. It should be that they should be in the cloud nine. They should enjoy it, and they should be the most important night. So unrealistic expectations about first night is very common. And if the most of the time it is, I tell them, see, it is more easier to fail rather than to have proper intercourse during first night. So don't give importance to that. Just being close to each other, enjoying each other's presence and the body, and not exactly the erection, penetration and ejaculation. Because most of the 80% of them really fail during the first night, and they should understand that it is not uncommon, and they should not feel bad about it. And after a few times of a few attempts, then it can get corrected. So only if it gets persistent problem, then only they have to see the doctor. Because this has to be told if they come to you for premarital counseling. And first night, it means don't have unrealistic expectation or exaggerated expectation, because of the performance anxiety, tension, lack of knowledge, and then wife also is tensed up. So many times men fail. So they immediately, the moment the man cannot perform, so she will run to her parents and tell and announce in the marriage hall itself he is impotent. And then the boy can never have the proper erection later. So that is the damage is done. The first night can become the last night also. So all these things one has to know. And about the intercourse, what's the frequency, whether, because so many times they have got their own, because the wife likes the light on and the husband does not like the light on. The husband likes the clothes to be off, but the wife does not want it. So there can be disparity. So they can communicate to each other and tell them what they like, what they don't like, and make the wife comfortable slowly. And with whether there is any female sexual dysfunction or male sexual dysfunction, the history, I'll tell you how you can detect that. And fatigue, fear, guilt, pressure of performance, fear of failure, and this about the sexual orientation. So many times the non-consummated marriage is because of the orientation, sexual orientation. The husband may be homosexual, and because of the family pressure, so he is forced into the marriage, and it's the wife who is the sufferer. So that sometimes this can happen. No, doctor, I don't get any attraction towards her. Then why did you marry? Because of my parents' pressure, I had to get married. I don't know what to do now. So what to do when say you will be spoiling the life of a girl? So you have to think about it earlier before spoiling the life of the other person. So then the sexual history, last sexual contact, if they say the last sexual contact is 6 months back, then you can understand. So something must be wrong. Or sometimes it happens that there can be disparity in the couple's desire. And the couples are having the sexual intercourse once in 6 months or the once in a year, they can be very happy couple. And the couple having the everyday sexual intercourse may be very unhappy couple. So it does not always depend on the frequency also. The timing, the consent, relationship, partner, types of sex involved. Sometimes the woman comes and complains, my husband wants me to do so many things. He watches blue films, and then he wants me to have anal intercourse and all that. I hate all that. I don't know what to do. So then again, you need to do the couple counseling. And whether they are using contraception, some of the contraception can interfere with the desire and other thing. So the other partner also, whether there are any other partners. In the marital history again, whether there was any premarital sexual experience or marital sexual experience. And this self-image, I have got patients who tell them, no doctor, my thighs are so fat, I am so fat, and I have got a lot of hairs on my body. I don't feel like unrobing in front of my husband, so I don't have much desire. I usually avoid having sexual intercourse. So the body image problem is very important for a woman. So first of all, she should have her own self-image, self-body image, and also the self-confidence. So it is not the body that is important, it is relationship that is important. So these things, so many times you may have to counsel them properly. Why exactly she is avoiding? She says, I don't have desire. And if she is suffering from PCOD and have become putting on weight and lot of hirsutism and all that, this will be her first complaint, that I don't feel like having intercourse because I am not looking good in front of my husband. So this is, and also the menopausal woman may think that she has lost her attraction, husband is not interested in her. So that is another time. So these are the things, whether you can also ask what is that thing that she likes in the husband, what the husband likes in her, and so that it is easy for you to counsel her. Relationship history, whether it is a good relationship, bad relationship, all the time quarreling, whether there is incompatibility, and which can always lead to divorce. And there are so many cases who come from family court, who come for counseling. I have seen the sexual problems is the commonest thing for which they go for divorce. And one couple had come and the wife had gone for divorce. And I asked her, why did you do that? Because then when I came to know that, then when I took the history, the husband did not have much knowledge and she had little more knowledge, and she was all the time telling she needs foreplay and she needs proper stimulation for arousal, but the husband was not understanding how to go about it. Then she said, I got fed up, and so many times I told him, and he is straight away coming for the penetration, which I do not like, I don't enjoy, and how many times to tell him, so I am fed up with him. So I have want a divorce. So when you properly counsel, when I counsel, then they became very loving couple, and the divorce was cancelled. So these are the things, and for non-consummation or for the erection problem, the couple can end up in divorce also. So after taking all this history, certain aspects of sexuality you have to understand. In human sexuality, psyche and soma are interdependent and combined. So there is a relationship with the body and the mind. Sexual response is combination of fundamental physiologic function and self-esteem, ego, social learning, personality traits, value systems, etc. It's a combination of so many things. So sexual problems do occur in persons who do well in other areas of health. Earlier, any person who has got sexual problems was straight away referred to the psychiatrist. And psychiatrists used to put them on antidepressants and anti-anxiety drugs. And after taking that, they used to become all the more depressed and all the time sleeping, and sexual problems were even exaggerated. So this is not like that. Any normal person without having any other problem can have sexual dysfunction or sexual problem. That the one has to understand. Sexual dysfunction may have its root in simpler problems. Not all the patients who have got problem will have the major problem, major disease. All this elaborate history is not at all needed. A simpler thing, just a fear of failure and just a fear of pain, which can lead to vaginismus. You remove that fear, the problem can be solved. Imaginary demand of sexual function. So many times the man or the youngsters, when they come, they say, I don't have erection. I think I'm suffering from erectile dysfunction. Why do you think like that? No, I tried myself and I wanted to have erection. It's not coming. So erection is a reflex action. So if they have got morning erections and if they have got erection on masturbation, the body is functioning perfectly normally. So only thing is he wants to have erection because it does not come on demand. So fear of rejection, humiliation by the partner itself can, each time there are so many couples, husbands come and complain. So of late I have developed some amount of disturbance for my erection at the age of 50. My wife thinks that whatever I was like how I was in my 25-30 years, she wants me to be like that only. There has been some problem. Now I have developed little difficulty. She all the time she'll be scolding and humiliating me for this. Then that's why when I have kept myself away from my wife and I don't have desire. So this itself can lead to, it can exaggerate further the sexual problem. The sexual appetite varies depending upon each person's sexual appetite is not same. Biologically, each person's desire can vary. Some can have little more of desire, some can have little less of desire. They're made like that, and this with the sex center and biologically like that. So that's the basic biological drive and the psychological need, their physical and mental health, anxiety, depression, pressure of performance, fear of failure, defective interpret. This may look very simple, but repeatedly these things come into picture when it comes to sexual dysfunction. And for the sexual problem, the cause may not be a single cause, it can be multiple also. There can be communication problem with the partner. They don't tell what they want, what they do not want. Simply they are showing their frustration, anger, and then quarreling. Negative attitude towards sex because of child sex abuse or the family orthodox upbringing or someone else's bad experience. So they can have negative attitude and a taboo topic, traumatic sexual experience, homosexual orientation, and all the other things which were discussed earlier. Other things are about alcohol, drug abuse, and sexually unresponsive partner. So many times the wife comes and complains. So many times when I show my desire, he will be scolding me, he will be pushing me away. So then I don't know what to do, and then I don't feel like having it again. So because all the time he is cold. When the man is having some problem like erection problem or ejaculation problem, the first thing he does is to keep away from that. And so because he is running away from that, and the wife thinks she is not attractive and the husband has lost interest in her, and that's why he is not coming. Maybe he is having extramarital affair. But when you really take the history, it is the husband who has got little disturbance, but he does not know that he can have treatment for that, which can be solved. So history taking, you also should remember that they take history of both the partners. It is the relationship to be treated and not the individual so many times. The biological and psychological, biopsychosocial model, we should always keep in mind. So guidelines are the simple guidelines with all the identification data, which can have a bearing on that, the occupation, education, and the age, and all these things, number of children, whether they come. And this is the most important thing you have to concentrate. You know that the sexual response cycle, we have, the person must have a desire. And once they are into the sexual relationship, there has to be an arousal. And after that arousal, during that, then penetration, vaginal intercourse for the penetration and the orgasm. So any of these places, whether it is at the desire level, whether it is at the arousal level, whether it is at the time of penetration, or whether they're enjoying it, orgasm. Usually they say, "Kushi milta hai," or "I'm enjoying," "I'm not enjoying," "I'm not feeling anything." These are the type they describe. They don't come and tell, "I don't have orgasm." So they will not tell, "I am not having white discharge." Or sometimes they complain of more of white discharge. So these are all the indirect ways of telling, "No, I'm not enjoying. I don't like it." So that is the desire. So desire is not a very simple thing. It's the most difficult thing to treat, desire level. So because so many things act on that, and it's not for a woman especially, it's very difficult to treat desire disorder. So then the arousal, whether station. Time is up.
Ma'am.
How much time is?
No, ma'am. Yes, ma'am. Okay, no issue, ma'am. No issue. Yeah, ma'am.
You can tell me how much time I should complete. I can complete.
Yeah, ma'am. You can. No issue, ma'am.
Because it is little important. So when this is the practical thing, when you, as per the sexual response cycle, take the history according to that, the desire, the arousal, lubrication, the penetration, and the orgasm, or whether there is any pain, whether she is enjoying or not enjoying. So this is if you categorize this, you will come down to a particular level where exactly is the problem. So the history as per sexual response cycle, all these things I told. In addition to that, the relationship, the satisfaction, and the partner problem. The most important thing is the partner problem, for which I will come. So in the desire, if there is lack of willingness to participate in any sexual activity, whether it is fantasy, masturbation, and coitus, that shows that the woman is having the less desire. The arousal disorder, lack of swelling and lubrication response, which can be subjective or physical. It was covered very well by Dr. Sharma. Orgasm, whether there is inability to achieve climax, it stops at pre-orgasmic level and there is no satisfaction. And sexual pain disorders also, which was covered very well. The superficial vagina, whether dyspareunia can be at the level of entrance at the superficial or in the vaginal after penetration, or it can be deep dyspareunia. And vaginismus, whether it is psychological or organic. And the key questions with each problem: onset, when did it start? How many, what's the duration? And the severity, whether either it's mild, moderate, or very severe, that she is really worried or she is really suffering. The course of the disease, whether it is intermittent or continuous. What are the exacerbating factors? Because the woman may say, in one particular position, in this position, if we have intercourse, I experience more pain. Because in the deep dyspareunia, in the deeper thrusting and deeper penetration, there may be more pain. And what are the relieving factors? If they change the posture or if they use some lubrication, that can relieve the problem. So these are all some factors which they are using, where they can explain to you whether there are any associated features and the previous episodes, how they were. And the problem can be situational or global. Only at particular timings it can happen, or it will be there all throughout all the time and all the places and all positions, and the mild severity, or it can be primary or secondary. And there can be use of questionnaires, which also was discussed. So this also can be used for the decreased sexual desire screener or female sexual function index. After knowing all that, taking the history, then if you give them these questionnaires, they will be able to fill it better and you will be able to understand it better. So history is taking specific to female sexual dysfunction. If you come, did she initiate the sexual activities or her partner? So this is also important, whether she is taking active participation. So many times husband complains that she does not like, she does not cooperate, or she does not take any interest in that. Only I have to force her, I have to tell her, and I have to have the intercourse, and reluctantly she participates. Whether her response, whether she refuses or sometimes refuses, or she is reluctant, or whether she is enjoying or having pleasure. And the other factors which influence level of sexual activity can be the problem, if she is suffering from chronic diseases or any other problem, or whether the partner's health problem is there, and the relationship, and lack of privacy. And this is a very common thing because of the small, how everyone will not have the luxury of having a separate bedroom and a separate bathroom, and in a small house there will be in-laws sleeping, or the brother-in-law, sister-in-law will be sleeping, and there is one curtain and very small place, and they don't have time for no privacy, and they don't have time for a proper sexual activity. They cannot afford to go to a hotel or go here, there, and how many times they can go. So you should also ask about the privacy. Very, very important. And recently I had a couple who came for infertility treatment, non-consummated for 3 years. And when I asked the wife, how can we are not at all able to have intercourse, how can we have pregnant? And nobody will understand my problem. My mother-in-law, she is only one room is there in our house, and mother-in-law has occupied that. And in the hall outside, and I had to sleep with my brother-in-law and my husband in the same place. And how can we have it? And nobody is understanding our problem. So when I called the mother-in-law, told her, she is blaming her that she is not conceiving yet. And when I told her, then she understood, and then she left that room, and so they could have privacy. And after 2 months, she conceived and came back. So this is the importance of privacy is also very, very important. And so the other thing which I was discussing is that they may not present to you with the direct symptoms. They may come to you repeatedly for the repeated backache, and any amount of treatment, orthopedic and gynec and so many places they would have gone, but the backache persists. And the pain in lower abdomen, the vaginal discharge. They think why discharge, they become weak, and that's why they are having problem repeatedly, because she is having arousal repeatedly, not having able to have intercourse with the husband. And any sexual arousal can cause this discharge, and she is scared and thinks something is wrong with her. And dyspareunia, headache. She comes and tells a headache repeatedly. I don't know why I am developed a headache these days. And sometimes depression, anxiety can be the symptom of her sexual disturbance itself. So unless you take the overall history, why is she having headache? Why is she becoming depressed? And why is she having all the problem? Why is she quarreling repeatedly? And why she is repeatedly coming to the gynecologist, even after giving so much of treatment and so much sometimes weakness, repeated weakness, and so much of these multivitamins, proteins and all that she has taken, still she comes and tells I am feeling weak. Only when she will be going from one doctor to other, thinking that at least some doctor will understand her problem and ask about sexual history. The moment you talk about that, she becomes so happy and so thankful to you. So this any of that repeated symptoms when the woman is coming, you please make it a point to take the sexual history. So detailed history about other things, about kissing, masturbation, foreplay, vaginal intercourse or oral sex, anal sex or sexual orientation. These are the other things that you can take the history. And the stage of woman's reproductive life, unlike the man, the woman will be passing through so various stages, important stages in her life, right from the adolescence, puberty, the premarital, postmarital, pregnancy, childbirth, menopause. So in various various stages of her life, she can have different sexual concerns and sexual problems. And depending on that, you have to take the history and also you have to go accordingly as per the problem. And menopause is the commonest thing. And now at least women are spending 1/3 of their lifetime post-menopause. And it can cause GSM, you all know about it. So you should be able to give her the proper quality of life by giving the proper advice for her sexual problems. And the effect of male sexual dysfunction. This is the husband, if he is not having proper knowledge and if there is lack of foreplay, and husband himself is having decreased libido, premature ejaculation or erectile dysfunction, this can indirectly, definitely can cause female sexual dysfunction. It can reduce her desire, not enjoying, not able to have arousal, not able to have orgasm. And sometimes it can also cause painful intercourse. So this, you should always make it a point, take a history of the partner and the male problems, whether it is there, which is indirectly causing women's problem. So finding out a problem is very important, whether she presents with a direct presentation or vague presentation, usage of words, the medical terms, sexual slangs, colloquial language, and use open questions when you're asking the history. So ultimately, history taking is an art in any disease. So, and all the more important in sexual problems. So sexual concerns, problems, dysfunctions, all these things can be addressed if the gynecology and sexual health is the best combination, I can tell you. With most of the problems you can solve and give the woman a holistic health, and she will be thankful to you throughout her lifetime. Thank you very much. With a good history taking, suitable investigations are advised to arrive at a diagnosis. Management depends on the sexual problem. So thank you very much for the patient hearing. Thanks for the opportunity.
Thank you, ma'am. Your lectures are really always an eye-opener for all of us, and it's cover everything. Thank you so much, ma'am. So I would like to invite the chairpersons, Dr. Anju Kanodia, ma'am, for your inputs. Anju, ma'am, over to you.
You have to unmute yourself, Anju madam.
Ma'am, you have to unmute yourself, Anju, ma'am. Yeah.
Thank you, ma'am. Thank you, ma'am. We are feeling very privileged by your talk. It was very wonderful and elaborative. And we came to know too much practical tips of taking history and management part in solving FSAID conditions. Thank you, ma'am.
Thank you very much.
Thank you so much, ma'am. And
Thank you.
my Mittal ma'am is there.
Dr. Padmini, wonderful talk.
Yeah.
Hello.
Yes, madam.
Yes, ma'am. You are audible. Yeah. Yeah. Please go ahead, Mala ma'am.
Yes, she has given a wonderful talk. She has covered it so nicely. Proper history taking is really very important to diagnose, evaluate, and give proper treatment. And she's right, history taking is their art. Proper history taking is very important for proper treatment. So thank you so much, Dr. Padmini, for wonderful talk.
Thanks. Thank you, chairpersons. Thank you very much.
Thank you.
Thank you. Thank you, chairpersons, Dr. Mala ma'am and Dr. Anju ma'am, and our wonderful speaker, Dr. Padmini ma'am. So over to Dr. Madan sir for the fourth talk. Madan sir, over to you.
Thank you, Dr. Apurva. Thank you, Padmini ma'am. It was very wonderful and detailed history taking.
Thank you.
We will move on to next session, which is on sex and sexuality in pregnancy.
No, Madan, Dr. Madhukiran's third one is there.
Oh.
Second one, female orgasmic disorder.
Okay.
Okay.
There is change.
Okay. You go finish this one, and Dr. Uma madam is last. Okay.
Yes.
Okay.
Yeah. I would like to invite the respected chairpersons, Dr. Pratima Singh and Dr. Shalini Agarwal ma'am. I would like to introduce Dr. Pratima Singh ma'am, who is Director, Pratima Maternity and Eye Research Center. Also, she is ex-secretary, Mau OBGY Society, and present time Vice President, Mau OBGY Society. And next, Dr. Shalini Agarwal ma'am, who is Senior Consultant of Khora Society. I request Pratima ma'am to take over.
Thank you, Doctor. Good evening, everyone. I am highly obliged to be a part of this CM, giving me an opportunity to introduce Dr. Madhu Kiran. She is renowned gynecologist and laparoscopic surgeon of Haldwani. She is Vice President of Haldwani of OBG Society. Her topic today, CME, is most important for today's and tomorrow. It's sex and sexuality in pregnancy. Now I invite Dr. Madhu.
Thank you, madam, for your kind introduction. I would like to thank Dr. Neeraj, the organizing committee, and chairpersons and the societies who have given me this chance. My topic for today's discussion is sex and sexuality in pregnancy. Just give me a minute to start. Can you see the screen now?
Yes, ma'am. It's yeah, ma'am. It's visible. Can you make it a full screen, ma'am? Is it possible?
Yeah. It is possible.
Okay.
I'll just.
Thank you.
Is it now full screen?
Yeah, ma'am.
Okay. So my topic for today is sex and sexuality in pregnancy. As we all know that all living beings are programmed for the most important biological function, that is to procreate. But in humans especially, this function has extended, or rather I should say has become dissociate, in the sense that the pregnancy is not now a contraindication for sexual activity, and the females are now trying to explore their sexuality right from adolescent period to perimenopausal and postmenopausal period, including pregnancy and postpartum period. So we have to be aware of the changing times, and we have to keep up with the times. So in today's talk, there are three key points that I will be discussing. One is, why are we talking of sex during pregnancy? Second, what we should know as clinicians. Third, how can it help in our practice? So as we all know, human sexuality involves biological, psychological, physical, emotional, and social feelings and behavior. It has shown to have health benefits like reduction in stress and blood pressure, increase immunity. It also helps people bond and build trust. Both pregnancy and sexuality are natural and normal phenomena of women's life. So sex during pregnancy is determined by a lot of factors, including emotional, hormonal, and anatomical factors. And these factors vary during the different trimesters. There is a growing awareness among people that sexuality matters, and females are now more aware and demanding, and it is not a taboo anymore to talk about the sexuality, even during pregnancy. And so more and more pregnant women are eager to celebrate pregnancy and are proud of it, and they want to talk about it and explore it. So when we come to a topic where over the years, over the time, there has been a conception that pregnancy means an absolute contraindication towards sex, there is a lot of knowledge gap that these females feel or these couples encounter. So we have to first understand what are the usual knowledge gaps and why these knowledge gaps are still there. Pregnancy or childbirth is not a disease. Sexual relationship is part of quality of life, and couples should not be denied of it if there is no pregnancy-related complications. Women and couple have plenty of questions regarding it, but are shy and hesitant to discuss. And as we have already discussed, that the sex education in India is so poor, and most of the young people never get any formal sex education. At the most, biology teacher will run through the reproductive system, and that is all the education that the young couples are going to get. And then they have no clue at any stage of their life to whom to go to and ask. Then doctors also think that it is not an issue to discuss, especially if it is not coming forth from the patient side. Unless one is familiar with scientific data, there is a potential of giving incorrect information or misleading the patient. So it's very important that as doctors, we should also be familiar with what we are talking today. And patients may rely on anecdotes, Google, WhatsApp University, and so many other unauthentic and informal ways to fill this gap. So we have seen, and all of you must have felt, that it's not just the rural and illiterate couples of females, but also the highly educated and the urban females who don't know and who have no clue about the sexual orientations, problems, or what they should and where they should go to ask. So when these women conceive and welcome their new bundle of joy, she starts getting advice from family members and others regarding everything, like what she should eat, how to sleep, when to sleep, what she should dress, where to travel, how to travel. But there is no one who can advise her about her sexual relationships. And what does this do? This leads to a self-imposed abstinence. 49% of women surveyed were concerned that intercourse could harm pregnancy. And 91% of pregnant women met the cutoff for sexual dysfunction in female sexual dysfunction index compared to non-gravid female counterparts. And so all this leads to a self-abstinence, self-imposed abstinence during pregnancy and the postpartum period. So as doctors, we have to understand that the sexual behavior of the female depends on a lot of factors, like her age, her cultural beliefs, the relationship she shares with her husband or partner, the physical changes that she's undergoing during pregnancy, the discomfort she perceives or feels because of those changes. Then there is a fear of fetal damage, especially in patients who are having bad obstetric history. And the partner's sexual function also affects her sexual experience during pregnancy. a lot of these females, in fact, all of these females are going through hormonal changes of giant magnitude in her body. There are various hormones affecting physical and mental aspects of sexual functioning in pregnancy. And progesterone, estrogen, prolactin, oxytocin, all are increasing and causing their physical and mental changes in the body of the patient. There are certain psychological changes also. So there is a definite decreased self-esteem in most of the females because of the increasing abdominal gut and other changes in her body. There is an anxiety related to pregnancy and the outcome and her body image. There is fear of damage to fetus. If there is any history, then the anxiety increases in these patients. Then there are body image issues and perceived loss of attractiveness because of the increasing gut. Then there are cultural differences in different families or regions. Then there are myths about sexual practices, and the interpersonal relationship also affects the sexuality during pregnancy. And all these things are arising from a definite physical change in the pregnant female. She's having nausea and vomiting, especially during first trimesters. There is urinary frequency, urgency, back pain starting from second trimester, increasing up to the third trimesters. And once she starts perceiving fetal movements, then there is a certain holding back towards the sexual needs of the female. Then the breast changes because of increased sizes, discomfort, and heaviness, and discharge from the nipple. Genital changes because of venous congestion, increased secretions, and heaviness. These all lead to a change in the sexual feeling of the female. But there is a definite decrease in sexual activity. In pregnancy, this could be accorded to the awkwardness of having coital positions, breast tenderness, decreased libido, dyspareunia, fatigue, fear of injury to fetus, genital vasocongestion, negative body image, physical discomfort, urinary frequency, and urgency. And in the postpartum period, this could be decrease could be attributed to dyspareunia because of the episiotomy scars and injury at the perineal area, episiotomy, pain, fatigue, milk leakage from the breast, nipple tenderness, and the sexual role change after delivery of the baby. So what should we do? We have to understand, as Dr. Padmini Madam has already said, we have to talk sex. The onus lies on the doctor to open up and bring up these subjects to their clients and patients, and we should start talking about these things. Be aware of sexuality concerns during pregnancy to answer the queries of couple. Most pregnant women can engage in sexual activity throughout pregnancy in absence of any complications. Sexual desire, libido, arousal, orgasm may vary during the 3 trimesters, and couples should keep some amount of intimacy throughout pregnancy, even if there are certain contraindications to penetrative sex. And although sexual desire may decrease in first trimester, most of the females agree that there are increase in sexual satisfaction during second and third trimester. So these couples may come to us and ask, will sex be different during pregnancy? So we have to understand ourselves that yes, sex definitely feels different during pregnancy. For some, it may be more, or for some, it may be a less pleasurable experience. There is definite increased blood flow to pelvic area, and there is an uncomfortable feeling of fullness. And this fullness sensation may heighten certain sensations in certain females and may cause discomfort in the others. Then more vaginal discharge causes more lubrication, and it helps to certain females, and to certain females, it may be a negative factor. And breast may remain sensitive to touch throughout pregnancy, And some females do not like their breasts to be touched at all during sexual activity. The next question which comes up is, will sex harm the baby? The baby does not get hurt by making love because it is protected from penetrative thirsting act by amniotic fluid surrounding it. Thick mucus plug in cervix helps guard against infection. An orgasm may cause mild uterine contractions due to release of oxytocin, but these are very temporary and harmless contractions. And increased baby movements during orgasm may be due to increased maternal heart rate and uterine contractions. So these are nothing, there is nothing which can harm the baby in the routine cases. But we also have to understand that pregnancy is not a contraindication for sex, but sex is contraindicated in certain definite situations, like all high-risk pregnancies, including toxemia, diabetes, anemia, bleeding per vaginal patients, abdominal pain, premature uterine contractions, leaking of membranes, low-lying placenta, previous bad obstetric histories, cervical incompetence, and patients whose partners have genital herpes. So, what could be complications of sex during pregnancy? Number one, what comes in mind is preterm labor. There is a definite theoretical fear of induction of labor by sexual activity, especially when nipple and genital stimulation may induce oxytocin release, causing mild uterine contractions. And sometimes prostaglandins released from mechanical stimulation of the cervix can cause cervical ripening. Prostaglandins in semen can cause cervical ripening, but 2 small studies found higher rates of prematurity in orgasmic women in third trimester, but all the other studies have failed to find any relationship between orgasmic frequency and prematurity, premature rupture of membrane, or low birth weight. So it is definitely just a theoretical fear. Then the fetal distress. Several studies initially have researched potential negative effect of maternal sexuality on the well-being of the newborn infant. But initial coital frequency during pregnancy was associated with fetal distress and perinatal deaths, but later investigation have observed no overall association. So there is no overall association of fetal distress with sex during pregnancy. Antepartum hemorrhage in placenta previa is one and most important contraindication because penile contact with cervix during intercourse can cause hemorrhage in placenta previa, and they have to be advised to abstain from sexual activity during pregnancy. Vaginal bleeding. Most females will come to you and say there was some vaginal bleeding or spotting after coitus. This is usually because of the hypercongestion of the cervix. But these patients will have a successful pregnancy. You have to understand that medical attention has to be given when the bleeding or spotting continues for several days or is associated with clots or heavy bleeding and abdominal cramping. Otherwise, small amount of bleeding or spotting is not a contraindication. PID and infections. As we have already said, theoretically, pregnant women should be at decreased risk for developing PID because of natural barriers to ascending infection created by mucus plug and obliteration of uterine cavity by 12 weeks of pregnancy. But some study groups suggested that women who had frequent intercourse and were colonized with trichomonas, mycoplasma, and bacterial vaginosis were at increased risk of preterm delivery. But we have to understand that frequent intercourse in women without such colonization were not associated with any preterm delivery. Venous air embolism. This is one of the most feared complication. If we have to grade the complications. Venous air embolism, a rare but potentially life-threatening event, has been reported in pregnant and peripartum patients having orogenital and penile vaginal sex, especially in rear entry position. 2 conditions must be present for this to happen. One is a direct communication between source of air and vasculature, and pressure gradient favoring passage of air into circulation. So the advice to these patients is to avoid orogenital sex and direct blowing of air in vagina. Otherwise, penile vaginal sex in rear entry position, where level of uterus is above the level of heart, may sometimes cause air embolism. But this is again a question which may be asked. Is it normal to have no sex during pregnancy? Yes, it is definitely and absolutely normal if you don't feel like having sex during pregnancy, because pregnancy hormones can decrease libido. And if a woman is unhappy or insecure or has relationship problems, she may not want to have sex during pregnancy. Some may consider this as normal. If one feels positive about pregnancy and related changes, she may not want to indulge in further sexual activities. But we have to understand that sex during pregnancy is not just a female's domain. The partner's behavior also matters. Man can feel as attracted as usual during first and second trimester, maybe because of abdominal girth, there may be a decreased attraction. Then there may be decrease in desire in the male also, because there may be a fear to harm the baby. There is worry and stress about wife and the unborn child. There is apprehension about the burden of parenthood. Then there is self-consciousness about making love in presence of unborn child. So when the patient comes and they do ask, and you have to advise, there are certain advice like the sexual positions that these couples may use during pregnancy. As pregnancy progresses, missionary position is not comfortable. So other positions can be advised, like woman on top, missionary, lying sideways positions, and coming to edge of the bed for the couple so that the female is not uncomfortable. In any position, deep penetration and pressure in abdomen should be avoided. So is oral or anal sex safe? Yes, because of certain reasons, patient may want to have these type of experiences, and normal oral sex won't harm the baby. But blowing into vagina should be avoided as it can cause air embolism. Vaginal penetration after anal penetration should be avoided to prevent spread of infection. And one large meta-analysis showed that up to 98.3% of pregnant women prefer genital to genital contact. And this is consistent with the non-pregnant cohort. That is, even in pregnancy, genital to genital contact is the most preferred method. Communication is key to maintaining and improving satisfaction during pregnancy, and in fact, during all the age span. And each couple should work to find techniques suitable for them. So what are the various sexual dysfunction that females and males face during pregnancy? More for females, mostly it is decreased libido. There is dyspareunia and anorgasmia. And for the males, it is decreased libido, PE and ED. Then there is lack of desire after delivery. So we are talking about pregnancy, and then now this is about postpartum. In postpartum period, the female is feeling exhausted. There is lack of sleep. The demands of motherhood are so high. There is high prolactin hormone. Estrogen levels are low. There is postnatal depression, fear, pain, stress, and if the delivery is by cesarean, there is a major operation, and the patient may feel very exhausted after delivery. And in this postpartum period, what advice should we give to the patient? We have to tell them, wait until bleeding stops and wounds have healed completely. Normal involution of genital tract has occurred. One is physically and emotionally ready for sex. And we also have to give at this time how to use contraceptives. This is very important advice at this time. Most studies advise to start 6 to 8 weeks after delivery, either normal or cesarean, but this is the postpartum period and you have to wait. And if even after that one is not ready to have sex, they can continue to have foreplay. So the advice to the patient is, try just cuddling and being intimate at first. Gradually get used to being sexually aroused. Enjoy each other's company with plenty of foreplay without expecting it to lead to penetrative sex. Try lubricating gel. Try making love during baby's nap time. Keep doing Kegels exercise to bring back pelvic floor tone. Eat well, drink plenty of fluids, and rest whenever possible so the stress levels are decreased. And if still the problem persists, please consult a doctor. And this is the most important message that has to come across to all the doctors and to all the patients through all these doctors. For any inquiry, ask your doctor. Thank you.
Thank you, ma'am. It was very nice explanation regarding the sex impregnation. It was really wonderful. I request the chairpersons to have their valuable comments. Yes. Dr. Pratima ma'am, Dr. Shalini ma'am.
Dr. Madhu, can you stop
please
sharing?
unshare your screen?
Yes,
Yeah,
thank
yeah.
you. Hello.
I'm trying to. Is it gone now?
No, not still is there.
Now it's gone. Now it's gone, I guess.
No, we can see that.
Anyways, by the time, because we're running short in time, we can get the feedback from the chairperson. Madan sir?
Yes, Pratima ma'am, please.
Yeah.
Apurva, you can on your hub, because as a host, you can do the stop sharing.
Dr. Poor, please do, because I am not getting where to I have to stop the screen share.
Click right next to Dr. Madhu and you can do that.
Ma'am, you just do one thing.
Yeah.
You just leave this Zoom. Then
Okay.
again, please rejoin.
Yeah, that is fine. I'll do that. Is it okay now, Apur?
No.
No, ma'am.
I've closed.
Ma'am, you have to unshare it. Please unshare it now.
Apur, I'm trying my best to unshare it. From where I'm supposed to do.
Ma'am, you can do one thing. Even I am just.
Please, Apur, please tell me, because I just don't understand from where.
I did it, ma'am. I did it. Okay, I did it. Yeah, now it's okay. Madan sir, please go ahead.
Yes. I request Dr. Pratima ma'am to have the valuable inputs.
Thank you, Madhukiran ma'am, for your nice and elaborate presentation. Thank you, ma'am.
Thank you very much.
Yes. Is there Shalini ma'am?
Shalini ma'am is there?
No, I think she's not.
I seen her. Shalini ma'am? Yeah, Shalini ma'am is there. Ma'am, you have to unmute yourself, please. Shalini ma'am. I think probably she is not here. So once he will join, we can go ahead because we're running short in time. So thank you so much, speaker Madhu ma'am, for the wonderful deliberation, and thank you so much, chairpersons, Madam Pratima ma'am and Dr. Shalini ma'am. So moving to our last talk for today, I would like to invite two very senior chairperson, Dr. Amber Khan ma'am and Dr. Niti Goel ma'am. So Niti ma'am is the senior consultant at Goel Nursing Home, Aligarh. She is being the treasurer of the Aligarh Menopause Society. Thank you so much, ma'am. Welcome, ma'am, for joining this. Second, Dr. Amber ma'am. Ma'am is the senior consultant at Mau, and at present she is the secretary of, sorry, I think. She is at present the secretary of the society. So thank you so much, ma'am, for joining. And I would like to invite Dr. Neeti, ma'am, to introduce our last speaker for today, our own Dr. Ruma Sukla, ma'am. Neeti, ma'am, over to you.
Thank you, sir. First of all, I would like to thank all the organizers for such a wonderful session. Even we all learned so much today. It's my proud privilege for me to introduce our speaker, Dr. Ruma Shukla, Director, Shukla Hospital, Indore, past President, Indore Gynecological Society. She will be telling us about female organism disorder. Over to you, ma'am. We welcome you.
Thank you very much, ma'am. First of all, I want to thank Dr. Neeraj for giving me and his team and all the societies who are arranging this webinar and giving me the platform. All the previous speakers were so extensive and elaborate in their deliberation that they made my task easy. I just want to share my PPT. Just let me give 1 minute. Yes, is my PPT is visible?
No, not yet. Only your whole screen. Yeah, now it is starting.
Yeah, actually my net connection is slow. Probably it is taking some time. It is taking time. So I will join with some other my PC. Just give me 1 minute.
Okay, okay.
Hello.
Yeah. It is taking time.
Hello.
मैम आजकल PowerPoint थोड़ा सा PPT जो है ना वो slow हो रहा है. Yeah. Now it's coming.
Yeah. Now it's visible. Okay.
Yes, ma'am, it's visible. Make it full screen, ma'am.
Yeah, just give me. Is it full screen now?
No, not yet.
Hello. Yeah. Now it is.
Now it's okay.
Yes, ma'am. Yes. It's moving also.
Okay. Yeah. Thank you so much for waiting. And as Dr. Padmini said, that this sex is the subject which is such a big taboo, especially in India, and we were not taught about sexual medicine even in our medical curriculum. Now, as a gynecologist, I started learning it, and the credit goes to Dr. Neeraj. Thanks, Neeraj and team, for making us aware of this and talking about it. So, what is orgasm? Orgasm is a sensation of intense pleasure, creating an altered conscious state in which pelvic striated, circumvaginal musculature, and uterine anal contractions occurs. Then there is a myotonia, which resolves sexually induced vasoconstriction, and this leads to well-being and sense of contentment. Biopsychosocial, Masters Johnson, and psychological definitions. They also supported and gave the same definition. Master Johnson has given a linear sexual response cycle, which was already told by Dr. Sharma in detail. So I'm not going in detail to this. In this, there is third phases of orgasm. What happens in orgasmic phase? This is a cerebral response phase of very short duration, only of few seconds. And then there is sudden release of sexual tension with increase in blood pressure, increase in respiratory rate, and the maximum concentration of the oxygen are there. That leads to involuntary muscle contractions of especially feet, uterus, vagina, anus, and all. And then this most powerful emotions which a human knows is of supreme bliss and ecstasy. There is explosive neuromuscular response at the peak of sexual arousal. DSM-5 describes female orgasmic disorder as a persistent or recurrent delay, infrequent or absence of orgasm, or some markedly diminished intensity of orgasm despite adequate sexual stimulation, and that should be present for at least 6 months in 75% or more occasions of sexual activity. And this all leads to significant distress in the person's individual or couple's life. How the physiology of orgasm works. The stimulation starts from the glans, clitoral complex, vaginal stimulation, anal stimulation, and then we have some deep vaginal erogenous zones like G spot, A spot, O spot, cervix, PFM, and all these work through pudendal nerve, pelvic nerve, hypogastric nerve, and vagus nerve. They causes stimulation in the sacral plexus, pelvic plexus, and leads to clitoral and vaginal orgasm. Similarly, stimulation of nipple and brain stimulation through intercostal muscles and oxytocin pathway also leads to clitoral and vaginal orgasm. What are the risk factors or etiology behind orgasmic disorders? So if there is some physiological causes like neurological diseases, cardiovascular problems, urogenital problems, gynecological problems, endocrine disorders, some cancers, some medicines like OCPs, SSRIs, these all precipitate orgasmic problems. In psychological causes, depression, anxiety, if there is some prior sexual abuse, assault, stress, or alcohol or substance abuse. Similarly, socio-cultural influences like inadequate education in the family and some social taboos, family values, they all lead to causes in orgasmic problem. Interpersonal relations like partners' performance, poor techniques, lack of interest or intimacy problems, or lack of privacy, they all leads to orgasmic problems. Some drugs which precipitates these disorders are SSRI, antipsychotic, antihypertensive, phenothiazines, antidepressants, OCPs, GnRH, tamoxifen, anticonvulsants, some chemotherapy, alcohol, cocaine, and narcotic use. These all leads to problem. So what is the prevalence rate? It is 18 to 40% of the women, which is quite high, are suffering for orgasmic disorders. And they don't come out of it. They don't tell you that they are having this problem. Even some of the women, they feel guilty that they are getting orgasm. They don't share their feelings with their partner or with their physicians. So we have to be very tender with them, talk to them properly, give them support so that they come out of it and we can help them in their problems. The types of the orgasmic disorders may be lifelong or it may be acquired. In primary female orgasmic disorder, the women never felt orgasm since beginning with in any partner with any kind of situations. And in secondary female orgasmic disorder, female usually have orgasm previously, but now she is not getting it. In acquired variety, because of some precipitating factors like stress, relation conflicts, or medication use, or some comorbidities, the patients are now not getting orgasms. How to assess? This is the crux of the treatment. The treatment and the diagnosis based on the self-reported symptoms. So we have to give them proper counseling, make a proper rapport building, give her a congenial atmosphere so she can talk to you confidentially. Ask in detail the quality, what is the type of orgasm she is getting, whether it is delayed, absent, or weak. Then course, how is the onset, duration, and the frequency? Is there any change over the time? So we have to ask in detail and ask the right questions. That is very important. As Padmini Madam has covered it in full detail, that we have to ask all the questions: who initiates, what is the frequency, type, and amount of the genital stimulation, whether she is satisfied it or not, how is the lubrication, the length and time of intercourse, whether she is able to achieve orgasm or not, is there any pain, is there any distraction, stress, or fatigue, if there is any partner's problem. And her sexual knowledge and skill is also very important, whether she is comfortable in talking or not. How is the sex values in the family? That is also very important. So ask in detail. Then we have to ask the couple also. First, we take the questions with the female, and then we take the questionnaire with the couple also, and ask them how is their communication, is there any, how is their affection, whether there is any conflict or distress or some interpersonal problem. So sometimes what they think, couple thinks whether I am normal or not, whether I am desirable or not. So we have to educate the couple regarding the physiology and anatomy of the sex and reproductive systems, and tell them that there is normal variations occur in sexual response. That is absolutely normal. They need not to get stressed about it. We have some adjustment scales available that shows, that gives us the idea about the intimate relationship. Then we have some female sexual function index. This is a scale of 19 items in which 3 items are for orgasmic functions, and this score shows us that whether the patient is having some sexual problem or not. So we can go ahead accordingly with that. Now, after the questionnaire, we have to do proper thorough physical examination that should include complete general examination, cardiac examination, neurological examination, mental state examination, and pelvic examination should be done in detail to rule out any genital discomfort, dyspareunia, vaginismus, see for if there is any infection, some laceration, or some old scar or some wound is there. Take the vaginal swab, that is important to create the vaginitis and all. Then some specific measures are also available, like tactile, vibratory, temperature perception thresholds are available, clitoral sensitivity tests are available, local vascular function assessment using photoplethysmography, this is also available, and Doppler USG is helpful for that. In lab testing, we have to do general blood test. Then in hormonal testing, we should go for TSH, thyroid, estradiol, FSH, LH. Prolactin is important to rule out hyperprolactinemia because that decreases libido. Testosterone, total and free testosterone is important to monitor the testosterone therapy. And choice of the treatment depends upon the level of the distress, a couple's need of sexual activity, marital status, fertility status, age of the patient, whether she is pre or post-menopausal, and association of other comorbidities. For treatment, give good counseling, lifestyle changes, treat the chronic illnesses. Behavioral therapy should include directed masturbation, sensate focus, sex therapy, psychotherapy, CBT, and mindfulness-based CBT, alternative therapies, stopping or changing the medicine. If because of some medicines this problem is arising, then either we should stop the medicine, see for if there is any change, or then if there is no change and the patient is still having some orgasmic disorder, then we have to change the medications. Then some medicines are also available for treatment of hyperactive disorders. Implicit model was elaborately described by Dr. Shama, so I'm not going through it. Then counseling, I have already said that alone and with the partner should be done, and we have to see if there is any relationship discord, give couple therapy, sex therapy, treat stress, anxiety, depression with stress reduction exercises, biofeedback, counseling, and psychotherapy. Normally, our approach should be comprehensive, so we can treat all the problems, whatever is precipitating this problem. In lifestyle changes, patients are advised to lose weight, healthy diet, exercising, especially pelvic floor strengthening exercises. Kegel exercises are very helpful in pelvic floor muscle strengthening. Stress reducing technique like yoga, meditation, stop smoking, alcohol, she should get enough sleep. And the main thing is their attitude should be changed towards the sex. It is not a taboo at all. So we have to provide them with sex books, videos, and they should be comfortable in talking about all these things. Their self-esteem should improve and they should accept their body as it is. In directed masturbation, this is a very helpful technique And it was found that 60 to 90% of the women become orgasmic after this. In this, couples are advised graded exposure to genital stimulation that should include role-playing orgasm, sexual fantasies, vibrators are used, and this all help in getting orgasm. Then we have to advise the couples regarding the comfortable position for intercourse that should avoid pain. They should learn to relax muscles around the introitus. There should be right balance between the tension and the relaxation, especially for orgasm. It is very important to relax in the mind rather than in the pelvis. And coital alignment techniques in which maximizing glans clitoral stimulation is important rather than deep penetration of the penis. Apart from this, vibrators or electrical stimulation devices for clitoris are helpful. Eros clitoral therapy is very helpful. The couple should be sexually assertive. What are the principles of sensitive focus therapy? It is a non-goal oriented physical intimacy in which we advise couple to not take the pressure of performance or getting orgasm. Rather than they should focus on the sensation of touching each other and explore the sensual touching rather than genitals touching. And this increases the intimacy and the bond. Yoga and mindfulness are an ancient art, and they target the overall physical health and the improvement of the stress level. So this helps in getting orgasm. Then in psychological therapies, cognitive behavioral therapy, mindfulness-based cognitive therapy, they all help in removing the distractions and stress level. Hypnosis provides direct and indirect ways of changes of negative thoughts. So that helps in getting orgasm. What medicines we have? Vasoactive drugs like PDE5 inhibitors, sildenafil, and etc. Hormones, estrogen, androgens, combined estrogen, testosterone, some nutraceuticals, thiombins, vitamins, and antioxidants. They are all helpful. In menopause and perimenopausal women, because of genitourinary syndrome, there is a lack of estrogen, and that causes vagina very thin, dry, and peppery, and which leads to itching and burning, dyspareunia. So for them, we have HRT, which are very good to help them. Topical estrogens, vaginal DHEA is also helpful. Hyaluronic acid, local anesthetic drugs, and laser therapies, they all help. Especially they should encourage to have regular sexual activity that prevents GSM. What local estrogen therapies we have? In vaginal tablets, cream, and rings are available. And the dose is initially daily for 2 weeks, and then maintenance dose is twice a week till the patient is having symptoms. Nitrizac gel is 5% L-arginine gel. That is also very helpful, and it should be applied once or twice a day. Then we have some drugs like flibanserin. It is FDA approved drug, 100 milligram daily, given at bedtime. Side effects are severe hypotension and syncope, and should not be given in with alcohol. Then some other drugs like BP101 and D-cycloserine, they are under clinical trial. Buspirone is another serotonin partial agonist drug used for HSDD. It is a off-label treatment. Dose is 5 milligram BD. Bremelanotide is US FDA approved drug available in the form of injection. 1.75 milligram of subcutaneous injection is to be given 45 minutes before activity. Then we have testosterone therapy. It's widely used, evidence-based off-label treatment, and especially helpful in peri and post-menopausal women. Available in the form of gel 1% and patches 300 microgram patches. Usually side effects are mild and reversible, but if the dose is given in a larger dose and prolonged period of time, then voice deepening and clitoromegaly is there. DHEA is more effective if it is used intravaginally. Then Arginmax is nutritional supplement. We have some non-surgical vaginal rejuvenation in our basket also. That is lasers, PRP, stem cells, fillers, and threads. They help in producing the collagen, and that improves the vaginal elasticity and functionality of the vaginal wall. This is also very helpful in patients who have survived cancer. And then we have some future options like PRP combined with hyaluronic acid that improves vaginal health index if it is given for 6 months. So another problem is of dyspareunia, in which we have to find out the cause. If there is an infection, then treat both the partners. Hormonal treatment for especially estrogen replacement, especially in menopausal women. Then some analgesics, lubricants, Kegel exercises, and treatment of the psychological and partners problem is required. Nutraceuticals is another effective module, like having L-arginine, zinc, and selenium. Then we have some herbal medicines and oils like ginseng, ginkgo biloba, ashwagandha, satavari, and various massage oils. Some surgery is recommended if the woman is having tight hymen or some pelvic diseases like PID, endometriosis, or adhesions, painful scars to be removed. Then hypertrophied scars, Botox for vaginismus is already told. Cosmetic dermatology for vaginal rejuvenation is a newer thing. So female orgasmic disorder is the second most common disorder of female sexual disorders, and we have to deal it with comprehensive assessment and the treatment. And if there is a problem with the partner, treat the partner along with sensitive focus, mindfulness therapy, cognitive and behavioral interventions. It was found that 20 to 30% of the marriages are breaking in India because of dissatisfaction in sexual life. So the hectic work schedules of the couple chasing their deals and dreams, that eats away their sexual vitality. We have to counsel them properly. About 10% of the couple, they check their mobile while doing the sex. So counsel them, explain them that it is important to invest into one's relationship, enjoy some couples time, grow intimacy and trust, rekindle the fire, be confident of one's body and sexuality, explore, experiment and experience, and always seek professional help rather than going to a quack. Thank you so much.
Madan?
Yes. Thank you, ma'am. It was really wonderful and very informative talk regarding orgasmic disorders. And thank you very much. I would like to request the chairpersons to have their valuable inputs.
Thank you, ma'am. It was a very crisp and informative session, and very basic things which we often neglect in taking history and all. It became very clear today. It was a very nice total overall. All the session is very, very informative. Thank you so much for making part of this.
Yes, thank you, ma'am. Is there Amber, ma'am?
Yeah, it is me, Amber Khan, Dr.
Okay.
Amber from Jaunpur.
Okay, sorry. Dr. Niti, ma'am?
He has covered almost all the aspects so nicely. And previously, a woman was considered only to do household work and look after children, but now a woman is also supposed to enjoy sex. So if she's facing any problem, I think she should communicate her issues with the husband and her spouse and with a doctor. And I think communication is very important to solve most of the sexual problems. And proper communication with the partner and the doctor can solve most of the sexual issues which we have discussed today. Thank you.
That's very right. Actually, what happens many times, women, they don't confide that they are getting orgasm. Rather, they feel guilty that they are getting orgasm. They even don't talk to their husbands. So it is very important that we should talk to them about all these things.
Yes. Thank you, madam. I would like to request Neeraj sir to have comments.
Yeah, vote of thanks. Finish with the vote of thanks.
Yes, sir. I would like to thank the Foxy office bearers, President and Secretary, ma'am, and on behalf of Sexual Medicine Committee, I would like to thank Dr. Neeraj sir for this wonderful webinar today. I would like to thank all the societies associated today, Aligarh Society, Bareily, Jaunpur, Mau, and Khora, all the office bearers of societies and all the delegates who have joined for this webinar, and also all the speakers, all the chairpersons, and the guest of honors, Dr. Pradeep ma'am, Rathi ma'am, and Verma ma'am, for attending this webinar on our request. It was a wonderful webinar, and thank you once again from the Sexual Medicine Committee of FOXI, and looking forward for your cooperation in future also.
Thank you for wonderful moderation, Apurva and Madan. You both did a fantastic job in moderating all the session. Thank you.
Thank you,
and
sir.
thank you all the faculties for joining today's webinar. I hope you found this very useful in your practice, and from tomorrow you will start taking interest in the sexual history, and just to put one board in your waiting area. If you have any sexual problem, contact us. That will lead to so many patients coming to you and exploring their problem with you, sharing their problem with you, and this will helpful in creating awareness also. Okay, yes, it can their problem can be solved here. So thank you.
Yes.
I want to say something.
Yes, madam. Yes, madam.
Yes, it was very wonderful. It was unspoken. Now it is started speaking us. Now we will be Gupta Rog Visheshagya, because persons those need, they used to wander here and there.
Yes.
Well, right? If we can treat your sex problems, everybody, we can solve their matters very easily. But only that we have to consult and we have to give more time for that.
Yes, madam.
It is really very nice. You have started something, and we will like to join your next webinars also. Please.
Thank you, madam. Thank you, madam.
Thank you. All the best to you.
Yes. Madan, you can stop sharing now.
Isn't it different?
Yes.
Therefore, we would like to you come as a VP in our
Yes.
society.
Thank you, madam, for your visit. Anyone else want to say anything? You are most welcome.
Actually,
Thank you, Dr. Neeraj. And you know that this is a very strong initiative which was needed, especially for all the gynecologists, and it will eventually help us in the long way.